Hello, hello, hello. How you guys doing? Let's see who's here today. I know it's a Friday. You prefer to be somewhere else, but you are here. Hey guys, who do we have here? Only the serious people are a minute early. Only the serious people are a minute early. Let's talk to the serious people. Let me open this webcam. Where's that webcam? Where's that button? Let me see. Oh, there you go. How you guys doing? Oh my God. It's day 5 of week 2. Can you believe it? That's crazy. If you think about it, we've been studying for 2 weeks. That's halfway through. Still have 2 more weeks. Oh my God. Are you guys excited? Hello, hello, hello. Are you guys excited? Oh my God, I'm so excited. I was so pumped for today. Today, I've got a surprise for you, right? If you feel lazy, if you feel sleepy, go right now, wash your face and come back, all right? I want you with a clear mind. So today we've got a surprise for y'all. Today is gonna be a longer webinar. Hey, you guys are happy, I know. Yes, so today is gonna be a longer webinar. Today I'm gonna slap your face and tell you wake up. If you are not on top of your studies, this is the time where you have to jump on your studies. All right. So you have to pick up the pace. If you still have things that you didn't listen to in the past or notes that you didn't read, you got to do it this weekend. All right. The test this weekend is going to be tomorrow, Saturday. It's going to determine how well are you picking up the pace, how well are you going to do on your NCLEX. I know we still have 2 more weeks, but this is a test for y'all. So close my cam because we have a long webinar tonight. All right. Grab your snacks, not now, on your first break. And then I'm going to close my webcam and we're going to jump into the webinar. I'm going to share my slides with y'all. By the way, thank you. Thank you all for the nice comments, down in the comments. You guys giving me some love. But let's see. I would like to welcome you to the live NCLEX webinar, the ultimate algorithm to pass your NCLEX on your very next attempt. And when I say the ultimate algorithm, you are a fool if you think that the ultimate algorithm is easy. It's not easy. It is hard work. No one has passed the NCLEX without putting in the hard work. Martha, Mahmoud, oh my God. Martha, Mahmoud, Jeannie, Tamara, Aduma, and the other Mahmoud, all of them have put the hard work in to pass their NCLEX. So I don't want you guys to be fooled and to think that passing the NCLEX is something that can be done by anyone. Any average nurse can pass the NCLEX. Any A nurse, if you are an A+ nurse, you cannot pass your NCLEX unless you prepare for it the right way. So I would like you guys to be one of those testimonials. And by the end of your 4 weeks, when you sit for your NCLEX, I would love to see you on the screen to motivate others who are going to be on this webinar. So I literally look forward for that moment. I know it's gonna happen one way or another. It's just a matter of time and hard work. So moving on, the road to become an alpha slice is a bumpy road. You need to put the hard work in. So welcome to your NCLEX RN intensive webinar course. We're jumping to the first question. This is a question from yesterday. We had we had a debate regarding warm compresses, cold compresses, so I had to look it up to give you the right information. And so apparently, if you apply a warm compress on engorgement, then that's a correct act that you will do. If you apply ice packs on the nipples for comfort, especially because infants, new mothers or because new breastfeeding mothers will have discomfort at the beginning of their breastfeeding journey in their nipples. So between feeds, if you apply ice packs, that will what's the word? That will give comfort to the mother. So ice packs on the nipples will give comfort, and warm packs, um, if the breast is engorged with milk and you do a massage or you put warm compresses, then that will help the milk to be released and will relieve the engorgement and the pain. Sometimes before breastfeeding, they put warm compresses just to facilitate that drainage of milk, make it easy on the infant. So that being said, the correct answers yesterday were 1 of 5. So moving on to the next question. Oh, am I echoing? Let me know. Is the audio clear now or it's not clear? I had my AirPods, that's why. And then I took them off. Okay, let's see. What about now? Just give me a yes or no. Is it echoing right now? Okay, awesome. Alrighty, those were the AirPods. All right, a patient diagnosed with AIDS is started to have hyperpigmentation skin lesions on his forearm. What complications is the patient having? So I'm going to read it again. A patient diagnosed with AIDS is started to have hyperpigmentation skin lesions on the forearm. What complication is the patient having? Kaposi sarcoma, varicella zoster virus, candidiasis, herpes zoster virus type 1. What do you think, guys? All right. So the questions that we've solved them several times before, we're gonna go through them very quickly. Most of you got the right answer. I would like to see everyone interacting down in the comments, but everyone is right. The correct answer is actually number 1. Hyperpigmented skin lesions are associated with Kaposi sarcoma, especially with patients with HIV and AIDS. Quick slide about Kaposi sarcoma. So Kaposi sarcoma is caused by infection with a virus called Kaposi sarcoma associated herpes virus, also known as human herpes virus 8. It is in the same family of EBV or Epstein-Barr virus, and this is how it looks like. I always try to put an image to a definition just to make sure that you guys would understand or would have that memory recall. Okay, so but from this question, I also wanted to explain varicella zoster virus, candidiasis, and herpes simplex virus type 2. So I want to put images to every single one of those. So this is Kaposi sarcoma. Just try to familiarize yourself with the image. And then this is the varicella zoster virus. So varicella zoster virus is caused by chickenpox and herpes zoster, also called shingles. Chickenpox follows initial exposure to the virus and is typically a relatively mild, self-limited childhood illness with a characteristic, let's see, exanthema, which is a contagious viral rash. And those patients, the varicella zoster virus will look like that. This is the rash. You've got the papules. If they break
then they are contagious. The only time you say chickenpox is not contagious is when those papules are crusted. So when they are crusted, they are not contagious anymore. But if they are like fluidy and liquid and they pop up and you've got secretions from them, then they are contagious. All right. And then we've got the candidiasis or Candida albicans. Candidiasis is a fungal infection caused by yeast that belong to the genus Candida. There are over 20 species of Candida yeast that can cause infection in human, the most common of which is Candida albicans. It develops yeast infection of the mouth, esophagus, and vagina. And just to let you know, Candida albicans are, or candidiasis or fungal infection in the oral mucosa or oral mucositis are very common among cancer patients and immunosuppressed patients. So if you've got a patient with HIV or a patient with any type of cancer receiving chemotherapy or any other forms of cancer treatment, then when their immunity drop, they will develop um, yeast infection or candida infection, fungal infection. Okay, so just keep that in mind. This is a picture actually of the fungal infection. Usually it is on the tongue and on the buccal area in the mouth. So buccal area and on the tongue. And sometimes they are not as severe as this picture, but sometimes they get way severe. So, and the last thing is the herpes simplex type 1. Uh, they are caused by herpes simplex virus. There are two kinds of herpes simplex virus. Herpes simplex virus 1, which is usually not the sexual transmitted disease and occurs on the lip. So that's what we are concerned about. We are concerned about herpes simplex virus type 1, which is usually on the lip or the corners of the lip or inside the mouth and occurs on the lip. And you've got the HSV type 2, which usually causes herpes genitalias in the vagina or on the penis, which is essentially an sexually transmitted disease in the genital area. Both viruses can be transmitted by saliva, body secretions, or oral sex. So, and this is the picture that see right there. That's the HSV type 1, herpes simplex virus type 1. Facts to keep in mind about HIV. We've seen this slide before, we're just gonna go over it very quickly. Oral esophageal infections like Candida are very common. Risk for Kaposi's, sarcoma, skin, and lymphoma. I believe on the first webinar or the second webinar, I said that Kaposi's sarcoma is not malignant, but then I corrected myself on day 4 or day 5 that Kaposi's sarcoma, I looked it up. It's malignant, and for patients to be treated from Kaposi's sarcoma, they receive chemotherapy. So just keep that in mind. Pancytopenia is when you've got when all the cells in the blood are low. So you've got low platelets, low white BCs, low neutrophils, low RBCs, low everything. So it's pan, which means everything, cytopenia, low cell count. So medical terminology is very important. Just keep in mind, you need to know it. Protective or reverse isolation if white blood cells are low. Cleaning, cleaning blood stains is usually with bleach and water, and the ratio is 1 to 10. And bleeding precautions, no IMs, no rectal temperatures if patients have low platelets. Not only with HIV patients, but with any patients who have any sort of immunosuppression. So just keep that in mind. Already? At today's webinar, we're going to review a lot of the slides in the past. That's why it's a longer webinar. I just want to make sure that you guys, so I'll be testing you with questions and then we'll be reviewing slides just to make sure that you guys, it's so we have to start taking things seriously from now on. We are 2 weeks in, we only have 2 weeks left. So by now, and I know how lazy people might be. You know, I am the same. My wife is the same. So the reason behind repeating slides halfway through just to remind you, hey, if you let go or if you didn't take a peek on those slides every now and then you might forget them. And these slides are very important for your NCLEX, all right? Okay, so moving on to the next question. Which assessment finding indicates to the nurse that the newborn is preterm? Presence of lanugo on the upper back, cheese-like gray-white fatty substance on elbows, breast buds of 0.8 centimeters in diameter, flaccid extremities that are extended when at rest. So which sign is basically means that the patient is preterm. What do I expect to see? 1 to 4. Okay, so again, we have two teams. Thank you all for participation. We have team number 1, team option number 1, and team option number 4. And team option number 4 wins. So when a patient extends like flaccid arms that are extended at rest, so the patient is preterm. Usually full-term patients, they have their limbs flexed. And a way to test their reflexes is to drop them a little bit, and then they will have those startle reflex or Moro reflex, and they will flare their hands and feet. But if they have flaccid extremities, that they are open at rest, then it means that the baby is preterm. Usually term newborns have flexed. They flex their hands, into their chest. So just keep that in mind. So another reason why I put these in the options, I want to explain them. Like I want you to have a picture to and the definition to everything in here. So number 1, we talked about lanugo. What I mean, like when I read lanugo and you read it it is very common on NCLEX questions. So if you see it a lot, if it is popular, then you need to put a picture to that word. You need to put a definition to that word. Okay, so that's what we're doing today. Lanugo actually is that fine soft hair, especially which covers the body and the limbs of the fetus or newborn. And you see the face; they are like soft or like, and those are not permanent. After the newborn is 2 to 3 months old, then you will not see them anymore. All right, so that's lanugo, and that greasy, whitish or cheesy like gray whitish fatty substance on the skin folds under the arms. They call them vernix sometimes. So you can see them on the elbows, groins, scrotum, labia. Usually use baby oil. Do not attempt to remove them. They say that you will mess up with the temperature of the infant's body. So I just want to give a brief definition. Now moving to the third question. The charge nurse is rounding on the orthopedic patients on the unit. Which observation to the NAP? Okay, so we're gonna read it again. The charge nurse is rounding on the orthopedic patients on the unit. Which observation to the NAP actions require intervention by the nurse? So read the options and choose one. Right? Give me an answer down in the comments. Let's see. Who got the right answer? Okay, I see 2s. I see 3s. What do you think? 48 hours post below the knee amputation, the NAP helps turn a patient who is onto his abdomen. So the NAP is helping the patient to his abdomen. The NAP lifts up the leg rest of the wheelchair. Okay, we'll read it again. The NAP lifts up the leg rest of the wheelchair of a patient wearing a hollow vest traction. Number 3, the NAP raises the patient's casted arm on a pillow. And number 4, the NAP is keeping an eye on the patient with hip spica cast who is performing ranges of motion exercises to the upper extremities. All right, so we've got team 2 and team 1, and the correct answer is actually 2, and we're gonna explain why. So if you pull up the leg rest of the wheelchair up and the patient is wearing a hollow vest traction, then the patient will fall down on his back, okay, because of the balance. The hollow vest is very, how do you say, it's very heavy, and the patient can lose balance if you lift up the leg of the wheelchair. So usually what you do is you keep them low. You do not lift them up. And number 1 was saying 48 hours post below the knee, the NAP turns a patient who is onto his abdomen. 48 hours post below the knee amputation, the NAP helps turn a patient who is onto his abdomen. So lying in prone position prevents hip flexion, contractures, and abduction, and it stretches the client's flexor muscles. Right, so that's the rationale. So you can put, I know in the past we said that we can only put patients with ARDS in the ICUs, ARDS, acute respiratory distress syndrome. We can put them on their abdomen for some sort of, for a little bit of time, just to improve their lung function or their oxygen ventilation mismatch. Other than that, I don't recall that there is a situation where you need to put the patient on their abdomen. But apparently this is one of the situations, the very rare situations where you can put the patient on the abdomen, which is to improve hip flexion, contractures, abduction, and stretch of flexor muscles. So that is it for this question. Everyone answered 1 and 2. Obviously, number 3 is fine. If the NAP wants to raise the patient's cast on a pillow, that's fine. Number 4, the NAP is keeping an eye on a patient with hip spica cast, and we're gonna see what's the hip spica cast, who is performing ranges of motion exercises to the upper extremities. So that's fine. She's just monitoring the patient. Okay. So this is the hollow vest traction actually. And if the patient is sitting on a wheelchair and you lift their legs, they will fall on their back. And this is the hip spica cast. So sometimes it's bilateral long leg, and sometimes it's 1.5 leg. So this is the way it is, right? Let's see. A psychiatric prison nurse is at a community meetup at a rehabilitation center talking to ex-convicts about different stressors after getting out of prison. The survivor of inmate partner violence is having anxiety issues and was asking about the appropriate therapy for his situation. The nurse's best response for therapy is psychodrama, group therapy, psychotropic drugs, or behavior modification. So basically the inmate, he had a partner in his room and he was abusing him in a violent situation. And after he's out of prison, he's having anxiety issues. So he's asking the psychiatric prison nurse about appropriate therapy for his situation. So what of these forms is an appropriate therapy? All right. I mean, I don't expect you guys to get this right, but the correct answer is actually number 2, which is group therapy. So for these type of patients, group therapy is the best kind of treatment. A psychodrama is a form of dramatic play in which the patient acts out emotional problems and explains subjective experiences, especially to like children and adults. So so this is where you use psychodrama. When an inmate is like doing a role play to teach children and adolescents. This is a way a this is a way of therapy that you use to help little children who are future criminals or who got in trouble, and to prevent them from getting in trouble, then an adult inmate would do a psychodrama, which is a role play of a certain act that got him in trouble and got him to prison. And then the youngest children would learn from their experience. So that's a type of therapy that is psychodrama. Then you've got group therapy, and then psychotropic drugs, which is self-explanatory, and then behavior modification, self-explanatory as well. Okay, so basically I wanted you guys to know what psychodrama means, and those type of patients who are having like flashbacks from when they were prisoners because they were abused, you use group therapy, or if there was talk therapy in the comments, then you select in the options, then you select that. All right, the nurse on a dialysis unit is ready to discharge the patient home on continuous ambulatory peritoneal dialysis. Okay, continuous ambulatory peritoneal dialysis. Which statement by the patient indicates proper understanding of the instructions? I will glass a drink. I will glass. Uh, so I will drink. I will drink a glass of distilled water every 2 hours. I will cover the catheter during dwell time. I will warm the dialysate before using it. I will disinfect the AV fistula with chlorhexidine twice a day. So which statement indicates proper understanding? So which statement is true? So three of those options are wrong, and one is true. Do I have answers? And from this question, I wanted to explain the difference between automated peritoneal dialysis and continuous ambulatory peritoneal dialysis, because I see both on NCLEX questions, and we only discussed one in previous webinars, so we want to give definition for both. Okay, awesome. So let me see. Okay, so most of you got it wrong, but and I know that your mind is playing tricks on you sometimes. Maybe like sometimes your mind start playing tricks on you. That's why I encourage to read the question again. So they want which statement by the patient indicates proper understanding. So what is true? Okay, what is true? So basically what's true is number two. Number one is wrong because you do not drink distilled water. You drink tap water or bottled water, but you do not drink distilled water. Okay. And number two is the correct answer. You cover the catheter during dwell time. So you don't keep your shirt up while you're actively, like on dialysis or actively washing out, whatever. And we'll say picture. Number three, I will warm the dialysate before using it. You do not warm it. It's room temperature. You keep it as it is. You do not put it in your abdomen, in your peritoneum, warm. You just keep it at room temperature. And number four, I will disinfect the AV fistula with chlorhexidine. You do not use chlorhexidine. And actually, there is no AV fistula with peritoneal dialysis. There is a peritoneal catheter. Okay. We'll explain dwelling time. So this is a brief definition about peritoneal dialysis. The inside lining of your own belly acts as a natural filter. Wastes are taken out by means of a cleansing fluid called dialysate, which is washed in and out of your belly in cycles. So as we said the last time on the last webinar, peritoneal dialysis, if you're doing the continuous peritoneal dialysis, then every 3 to 4 hours you go to the bathroom, or you go whatever to a private place and you put the dialysate, you hook it up with via tubing to your peritoneal dialysis, and then you let it run inside your abdomen or inside your peritoneum, and then you lock it, you leave it there for 4 to 4 hours, then you drain it and you install dialysate again. And we're gonna see a picture. How does peritoneal dialysis work? A soft plastic tube, which is the catheter, is placed in your belly by surgery. A sterile cleansing fluid is put into your belly through this catheter, which is the dialysate. After the filtering process is finished, the fluid leaves your body through the catheter. So the filtering process is 3 to 4 hours. Okay, so that's the period. And that's the dwelling time. Dwelling time is when the dialysate is sitting in your abdomen. So there are two kinds of peritoneal dialysis, and that's what I wanted to explain. Continuous ambulatory peritoneal dialysis, and then automated peritoneal dialysis. So the continuous ambulatory peritoneal dialysis, and you might like have a little bit of confusion, but basically it is when you, so it's the first one. When you go to the bathroom, you put the dialysate, you put it down in your tummy. After 3 or 4 hours, you drain it, and then you put dialysate again. So every time you go to the bathroom, you drain the wastes, and then you put a new dialysate into your abdomen. And then 3 to 4 hours, you come back and you do the same process all over again. So this is continuous. Ambulatory means like you do it on your own. You don't have to be in a hospital setting or at home or whatever. But the automated peritoneal dialysis, you have to be at home. You'll have this type of machine. Usually they do it at night. You hook it up to your catheter and then you sleep, and it will keep cleansing your body all over the night. And then during the morning you detach it and you go to work and do whatever you want. But at night, so usually every 12 hours, you you do this dialysis act once every 12 hours, and usually during night while you're sleeping. The difference where you might get mixed up is with the word continuous. So you would feel that continuous because you're sleeping all night and the machine is doing its dialysis all over the night, so it's like continuous. You might think that the continuous ambulatory peritoneal dialysis is this one, which is wrong. So just make sure that you understand both and you know what's the difference between them. Okay? Alrighty. The new nurse on the med-surg unit makes a medication error. Which actions are appropriate to take in this situation? Select all that apply. So number one, document the dose given in the patient's MR, which is the medical medication administration record. Number two, state in your progress note the error and that an incident report was initiated. Number three, assess the patient for any harm from the error. Number four, inform the attending physician. Number five, document in the medical record any side effects the patient might have. Number six, complete an incident report 24 to 48 hours after the incident. And again, when you do select all or apply, just treat them as true or false. And after you pick up, after you choose your picks, let us say you chose 1, 2, and 6, then go over 1, 2, and 6 again and treat them as true or false. Okay. So when you feel you're ready, just give me your answers. All right, awesome. Awesome. Some of you got the right answer. Actually, there are a few tricks in this question, so if you didn't get it right, it's the learning process. There are things I wanted to point out in this question. Alrighty. So the correct answers are actually 1, 3, 4, and 5. And 1, so you document the dose that you gave. Okay, if you gave a wrong dose, like if you gave a double dose, you sign both doses because you gave them to the patient. Like you cannot give a dose and not sign it. Okay, that goes in his medical record. Number 2, state in your progress note that the error, state in your progress note the error and that an incident report is initiated. You do not do that. You do not say in your progress note that an incident report was initiated or an error happened. You do not do that. What you do is you say you keep it subjective. So you keep it objective. So what you do, you say a double dose of vancomycin, for example, was given. The patient is not having any signs of symptoms. The nurse is monitoring the patient closely every 15 minutes, period. But you do not say error, and you do not mention anything about incident report. Usually incident report in the hospitals or in healthcare, they do not go into medical records. They do not go into the patient's record. They are a hospital quality indicator. It's the incident report is for the hospital only to improve their practices and learn from their mistakes, but they do not go into the patient's records. And this is a big deal in the United States just because of the insurance companies and coverage and stuff like that. So always, if there's an error that happened, you document the error without writing error. So you say a double dose of vancomycin or another dose of vancomycin was given at this time or whatever, and you say the patient is not having any signs of symptoms. The physician is aware, and the nurse is keeping a close eye on the patient or monitoring the patient every 15 minutes or whatever the case is. Okay, so I just want you to know that because this is very, very important. All right. So it's not subjective, it's objective. Just write whatever happened as it happened without analyzing it. Okay, if the patient is having signs and symptoms, write that he is having signs and symptoms. So let's say you gave a medication, you gave double dose of vancomycin, the patient had Brodmann syndrome, the doctor is informed, anti-allergic meds were given, the vancomycin was stopped. So you document what happened, but without saying that it is an error. Okay, you just document what's happening with the patient, but you do not state that it is an error, and you do not put in the patient medical records that an incident has happened. Because if they are auditing like an external company or like Medicare or whatever that the other party are auditing the medical records and they see incident reports, then they will go into who did the mistake and what happened, what's the consequence, all this kind of stuff that it's well known in the United States. You do not do that. And then there will be some coverage and insurance issues. All right, let's see. And number 3, actually assess the patient for any harm from the error. That's true. Inform the attending physician. That's true. You do it. Number 5, document in the medical records any side effects of the patient that might happen. That's true. You just document what happened. If no signs and symptoms happen, you say the patient, was stable during my shift, like for the next 12 hours or so. And then complete an incident report 24 to 48 hours after the incident, you do not wait 24 hours to document the report. You initiate the incident report directly after the incident. Okay, so you take care of the patient and then you initiate the incident report. All right. The oncology nurse is giving a teach about risk factors and demographics of lung cancer at a community gathering at a local community clinic. Which group of individuals has highest risk of lung cancer? Okay, so basically that's the keyword, the last part. Which individuals have the highest risk of lung cancer? African Americans, Caucasians, Southeast Asians, Latins. This is just a like quick tip just to keep in mind. Just like the sickle cell anemia patients, sickle cell is very common among African Americans, and from this question we want to learn lung cancer is most common among which patient population. All right, awesome. So a lot of you got the right answer, which is number 1, African Americans. So keep in mind, lung cancer, sickle cell anemia are most common among African Americans. Okay, just keep that in mind. All right. A medical surgical nurse admitted to a new a medical surgical nurse admitted a newly diagnosed. Oh, okay. So a medical surgical nurse admitted a newly diagnosed patient with DVT, deep vein thrombosis. The provider prescribes warfarin 20 milligram twice a day for the first 15 days of therapy. While collecting the initial assessment history, which statement would warrant the nurse to hold warfarin and contact the provider immediately? Select all and apply. Number 1, patient had a bilateral cataract 2 weeks ago. 2, recent endoscopy revealed a gastric ulcer. Number 3, patient is a daily alcohol consumer. Number 4, patient is on baby aspirin daily for the past 5 days. Number 5, recent colonoscopy reveals multiple polyps. What do you guys think? So this is select all that apply, okay? Let's see. And in today's webinar, I know we've touched on warfarin and heparin in the past, but today we're going to talk in details about warfarin and heparin because I literally want you guys to master those because they are very popular in the first 75 questions of NCLEX. All right, awesome. So some of you got the right answer, got it on point. Okay, some of you didn't. So actually the correct answer is 2, 3, and 4, and we're gonna explain why. So number 1, it does not. So what I'm looking for is I'm giving anticoagulant for a patient, and any risk for bleeding I want to eliminate. Okay, so I do not give warfarin to patients who are risk for bleeding. So number 1, if a patient did a cataract 2 weeks ago, basically there is no risk for bleeding. If that was a fresh OR or a couple of days, after the OR, then I would think about, bleeding or infection or bleeding or infection. But in this case, there's no indication that the patient is at risk for bleeding. Number 2, we have a gastric ulcer, then definitely I'm picking that. Number 3, a patient is a daily alcohol consumer. I will definitely pick that up because alcohol and warfarin, they do not go together. First, they will have interaction, and second, alcohol will. So if he's a daily alcohol consumer, that will impair the liver, and warfarin works on the liver. vitamin K in the liver, and coagulation factors are in the liver. So if the patient is drinking alcohol, then his liver enzymes are messed up. Then warfarin would then you need to monitor the warfarin dose, because the warfarin would if you give like 20 milligram of warfarin, it will not be excreted outside of the system, and then accumulative doses will put the patient at risk for bleeding. So a normal patient, if you give him, let us say, if you give warfarin, it takes them 20 or 12 hours to get out of their system. But with patients with liver disease or liver cirrhosis or liver impairment, it would take them longer time to get out of their system. Okay. And then you've got number 4. So aspirin, for the past 5 days, patient is on baby aspirin for the past 5 days. So that aspirin has a side effect of peptic ulcer. So if you give warfarin, you're putting the patient at a higher risk for bleeding. Aspirin is antiplatelet aggregation, so it's not anticoagulant, but it has a side effect of peptic ulcer. And then you need to warn your doctor or immediately inform your physician, because there is a risk factor for bleeding. And basically, number 5, colonoscopy revealed multiple polyps. If those polyps were bleeding, then I would choose that. But if it just said colonoscopy revealed polyps, so polyps are closed polyps, basically, like a bulb, or it's not a papule, but it's like a bulb. And these are indicated, usually you biopsy polyps because they could be cancer, colon cancer. But number 5, you do not choose it because there's no risk for bleeding. Okay. So what are the things that you do not want with alcohol? Okay, it's commonly known that do not mix alcohol with medication, because it will potentiate their effect. Okay, it will increase their half-life, and they will stay in the system for a longer period of time. So you do not mix alcohol and medication. You do not operate heavy machinery. So you do not drink and drive a car. So well known. You do not be responsible for kids under the age of 12. And that is well known. Like that is a law in the United States. You cannot take care or babysit kids less than 12 years old if you are under the influence of alcohol. And believe it or not, if you are under the influence of painkillers like narcotics, like narco, if you are taking narco, then you cannot babysit children or kids below the age of 12. So it's the same thing. So don'ts with alcohol and narcotics. So do not mix narcotics with alcohol, not with other medication. Do not mix narcotics with alcohol. Do not operate heavy machinery if you are on narcotics like narco. So you do not take narco and drive, and you are not supposed to be responsible for babysitting kids under the age of 12 if you're taking narco or under the influence of alcohol. All right. And now we're going to talk about anticoagulants. So I put this little table together, and we're going to compare heparin and Coumadin. And literally, like just like the insulin table, just like that, you print it out, put it on your study wall. I want you, or like if you have a diary, or you have a notebook, just print this table out and stick it on a piece of paper in your notebook and refer to it every now and then. So anticoagulants, you've got oral anticoagulants like Coumadin or warfarin, and you've got IV or sub-Q anticoagulant, which is heparin. Okay, so what's the difference in terms of route, onset, treatment period, antidote? What are the things you need to monitor, and are they safe during pregnancy or not? Okay, so we'll go over those. Heparin route, as I said, it's IV or sub-Q, while Coumadin, it's PO. Onset, it's immediately, like as soon as you give heparin, the patient is at risk for bleeding. Okay, Coumadin, it needs 3 days, 2 to 3 days. That's why when you have patients who who just did a coronography and they are diagnosed with coronary artery disease. So the physician directly put them on IV heparin, like continuous infusion, and they start them on PO Coumadin. So the patient will be on both for a period of 2 to 3 days until the Coumadin takes effect. Then they start tapering the heparin and will discharge the patient on Coumadin. So that's an NCLEX question as well. Keep it in mind. And then you've got the treatment period. Can I give heparin forever? I cannot give heparin forever. Heparin can only be given over 21 days. After that, you give Lovenox. So Lovenox, they refer to it as, what do they refer to it as? Lovenox is a, oh my God, it just slipped my mind. Lovenox is a, all right, it will come back to me. Anyways, so you switch the patients on Lovenox, and then they will take Lovenox twice a day, depending on their weight. But Coumadin is low molecular weight heparin. Thank you, thank you, my man. It just slipped my mind. I swear to God, it slipped my mind. All right, so Lovenox is a low molecular weight heparin, but you can give it for lifetime. But heparin, you can only give it for 21 days. So, and then you give, and then after that, you give Lovenox. Coumadin, you can give it for a lifetime. It does not matter, okay? And the antidote for heparin is protamine sulfate. We said that in the past. For Coumadin or warfarin, it's vitamin K. What are the things you need to monitor for heparin? PTT, okay? PTT for heparin. Coumadin, INR, or PT. Just don't mix between the two. If you have a way to memorize them, do. I would just memorize one of them. Okay, I would memorize heparin, PTT. Okay, and then the PO is the opposite. It's the INR. Is heparin safe during pregnancy? Yes, it is safe during pregnancy. It's a class C. And now you're gonna ask me, what's class C? Like, no, what's class A? What's class B? What's class C? Hey, listen, I've got your back. Next slide. And Coumadin, is it safe with pregnancy? No, it is not. Okay, those are NCLEX questions, real NCLEX questions. So make sure you know the slide, you know it very well, and don't mix up between the two. So these are, I know this is a little bit hazy. These are the classifications for drug risks for pregnant women. So category A, B, C, D, and E. I'm not gonna go through all of them. Category C, which is our case, which is the heparin. So no controlled studies have been conducted in animals or humans. So it's like safe. Like you're going blindly, but it's safe. All right, moving on. A 45-year-old patient admitted through the emergency department with a newly diagnosed cerebrovascular accident. The provider ordered several referrals or consultations. Okay, in the United States, they call them referrals. Which referral is most important for the nurse to work on first? So a patient had a CVA, and the provider ordered a bunch of referrals. Which referral should the nurse start working on first? Speech pathologist, physical therapist, skilled nursing home, or clinical psychologist? I want to see wrong answers, guys. We've talked about this, like strokes, CVA patients, they always come with 3 or 4. You know, when you see an NCLEX question and you've got CVA, there are 3 or 4 things you have to keep in mind. The answer is going to be between those. Okay, they just flip them over and over again. All right, so most of you got the right answer, which is speech pathologist. And let me explain why. So CVA patients are at risk for aspiration, and that's the #1 safety issue that you need to focus on. Yes, you need to focus on fall and injury if the patient is in a hospital setting in his bed, but you need to keep in mind that those patient population will have speech problems and will have aspiration problems. And aspiration might get them into a very serious situation with pneumonia, and they will not recover very easily. So speech therapist to assess their swallowing, okay? And those type of patients, when you want to feed them, you put them in semi-fallow position, and you put them in semi-fallow position at all times just to prevent aspiration. Okay, sometimes the patient is in bed and they have like some sort of vomiting or whatever, and because of the paralytic muscles in that area, because they have some sort of hemiplegia, then they might aspirate the vomiting instead of vomiting, the gastric content outside of their mouth. So they might choke on vomiting. Okay, so keep that in mind at all times. That's very, very important with patients, CVA patients. The nurse is planning a teach for a 61-year-old patient with history of recurrent lung infections. Which instructions does the nurse include in the teaching? So the patient is always coming with recurrent lung infections. Number one, avoid moderate intensity cardio activities like running. Number two, don't go outdoors during the winter season. Number three, keep fluid consumption under 1 liter per day. And number four, don't forget to get your flu shot on a yearly basis. You might get tricked with some of these options. Okay, but we're putting this question here for a reason. I don't want you to get a wrong answer later on. Alrighty, so most of you got the right answer. I like that. Flu shot is very important on a yearly basis to prevent flu symptoms, lung infections, pneumonia, any sort of lung infection. You always encourage elderly, especially the elderly, you encourage everyone in the United States to take the flu shot. And sometimes during the flu season, flu shots are for free. You just, when you go to, and for some of you who live in the United States, know during the flu season, getting a flu shot is just like you don't have to go to a hospital or to a clinic or whatever to take your flu shot. Literally, flu shot are drive through. The same way you drive through McDonald's and pick up your burger, you drive through. They put camps in parking lots or at pharmacies like Walgreens or CVS or something. They put drive through parking lots, and there will be nurses holding flu shots. You just stick your arm out of the window and then bam, you get your shot. So it's like that. So just make sure you tell patients to get their flu shot. Okay. Well, moving on, a 15-year-old patient fractured his radius bone during gymnastics. During the follow-up visit, the patient asks about measures to relieve itching under the cast. Which response by the nurse is accurate? Use a blow dryer, apply cool air under the cast. Number two, wrap a sterile gauze, this is a gauze, wrap a sterile gauze on a tongue depressor and scratch the itching area. Number three, apply ice chips under the cast whenever it itches. And number four, put hydrocortisone cream on a sterile gauze and apply on the area that itches. Right, I know most of you will get this correct, but just to reinforce information, because we do not want any surprises on your NCLEX. Okay, so most of you got the right answer, which is number one. What you do is you blow a hair dryer inside the cast and you apply cool air. Okay, you do not apply warm air. First, it will make the itching worse, and then it will make the arm sweat under the cast, and that will cause humidity, and it might cause some sort of yeast or whatever. So it might cause humidity under the cast, and that will give a medium for infection. So you always apply cool air, which is very, very effective if a patient is having itching under the cast. And itching under the cast, if some of you have broken their arm before, you would know, or your leg, you would know, or you had a cast before, you would know that it itches on a daily basis. Okay? Alrighty, so moving on. After being in a long-term care facility, and let me just say that some of you who are not in the States, and when I wasn't in the States, I couldn't understand what they mean by long-term care facility. Okay, long-term care facilities are just like nursing homes. They just call them long-term care facilities. Maybe that's a sophisticated term for a nursing home, but every time you see long-term care facility, just think of a nursing home. So after being in a long-term care facility for a month due to rehabilitation from a back injury, a 60-year-old patient asks the nurse about exercises to improve and maintain optimal musculoskeletal function. Which response by the nurse is best? Do not perform weight-bearing exercises, high-intensity resistance training, putting on muscle in older adults is an unrealistic goal, and number 4, older adults should stick to walking as a form of exercise to maintain activity. What do you guys think? For these type of questions, always try to use cancellation. When you first, go through the answers, try to cancel 2 out of the 4. Because, like on most questions, you can cancel at least 1, if not 2. Okay. I have never encountered an NCLEX questions where I could not cancel at least one option. So always try to cancel and then try to use nursing strategies, NCLEX strategies, I mean. All right, so I do not see any correct answers so far, but that's fine. We're gonna explain them. Like when I read such questions, this is how I think. This is my mindset. So basically, what we have 2 teams. Again, we have team option number 1 and team option number 4. But the correct answer is actually number 2. So you do high intensity resistance training. The reason you do not, so number 1, you actually tell them to do weight bearing exercises. So when the nurse is saying do not perform weight bearing exercises, that's wrong. You should tell them perform, go ahead and perform weight bearing exercises. And number 2, tell them do high intensity resistance training. Okay. And number 3, you tell them it is realistic to gain muscle. We're not saying you're gonna be a bodybuilder, but you can improve your musculoskeletal function. So it is a realistic goal for an elderly patient to gain muscle. And number 4, don't tell them stick to walking. No, they can do way more than that. So, so if the back injury, if the patient recovered from back injury, they are recovered, then and they want to improve their musculoskeletal function, then you tell them to perform weight bearing exercises. Okay, we're not saying put 100 pounds on your back and squat. No, but they should do weight bearing exercises and they should do high intensity resistance training. Okay, just keep that in mind. Resistance training is training with weights and working against resistance. So it could be like a medicine ball, it could be like your so resistance, like so the muscle is going to failure, but then you keep on doing the repetition or the exercise, just, or sometimes they use the band, like a band, resistance band, and they perform certain exercises, like whatever. Google it, resistance bands. Okay, you know what, let's Google it together, even better. Okay, let me bring my Google. Bang. Oh, I didn't want to show you this. This is the code for today. All right. Google resistance bands. So these are actually resistance bands, but we'll look at images. So these are resistance bands, these are resistance training, these are resistance training. So now you know, right? Google's your best friend, guys. Alrighty. Wait a second. Where did that go? All right. So we'll move to the next question. Rumors on the medical surgical unit suspects that the new hired nurse is using cocaine. Which observation are suggestive of that accusation? So there are rumors that the new hired nurse is abusing substance. So if it's cocaine or something else, but in this case, it's cocaine. So which observation are suggestive of that accusation? Number one, sneezing, headache, and fever. Two, diarrhea, nausea, and stomach cramps. Number three, fatigue, weakness, and mydriasis. Number four, lack of sleep, runny nose, and facial pain. What do you guys think? Okay, mydriasis is actually the widening of the pupils. So mydriasis is the widening of the pupils. All right, so let me see, did anyone, actually none of you got the right answer. All of you answered, or maybe some of you got the right answer. Okay, so the correct answer is number four, actually. It is lack of sleep, runny nose, and facial pain. So lack of sleep, just for the fact that cocaine, if you take cocaine, man, you're hyper. You do not sleep for ages. Like you have energy that, I mean, you can do anything and everything in the world. You do not feel tired. It's an excitatory substance. You feel energetic all the time. Okay, if you are on cocaine. If you have a runny nose, then that's a sign that you are on cocaine because usually they sniff cocaine. Okay, and I do not know that from experience, just from the movies. And then facial pain, patients on cocaine have facial pain. Okay, and one of the reasons is because you're sniffing it. Sometimes you trigger that facial nerve, and it will cause your facial muscles to twitch, or it will cause them pain. Okay, number four, sneezing, headache, fever. These are flu symptoms. Number two, diarrhea, nauseating, stomach cramps. These are like colitis or any abdominal, like, so any like food poisoning. It could be this number two could be food poisoning. Number three, fatigue, weakness, and mydriasis. Some of you answered this. Usually, it is not mydriasis. It's the opposite. What's the opposite of mydriasis? Like pinpoint pupils. So it's constriction of pupils, but not dilation of pupils. All right, and usually they are not fatigued and weak, and they are so strong. Trust me. So people on cocaine are very strong, very energetic. So it's not number three. Okay, so make sure that you know what cocaine is. Cocaine is an excitatory substance. So we're gonna have a couple of slides that are gonna talk about substance use and side effects. Familiarize yourself with those slides and with those substances, because you will get a question on the NCLEX. Okay, it's very common in the United States. Every state, especially the northern states, like drug smuggling and drug dealers, and they are everywhere. I'm telling you, don't tell anyone, don't tell I said so, but they are everywhere in the United States. So and I mean, the government knows they want you to take care of these patient populations. So this is a very common NCLEX question. All right. Okay. Someone asked why not two. I mean, these are food poisoning symptoms. They're not cocaine. They're not cocaine. I mean, sometimes you need to rationale. rationale the symptoms and just know that these are not the right symptoms, even though that they are excitatory, right? Diarrhea, excitatory, and stomach cramps, excitatory, nausea, excitatory. But still, those particular symptoms are not cocaine-based symptoms. All right. Let me see. So the number two, option number two, diarrhea, nausea, stomach cramps, these are excitatory symptoms. So let us say, if it is true, okay, that diarrhea, cocaine causes diarrhea, or cocaine causes nausea, but the hallmark symptoms of cocaine abuse or cocaine use are number four: lack of sleep, runny nose, and facial pain. Okay, let's just make it this way. Substance use, you've got uppers, you've got downers, right? Uppers, like what? Caffeine, cocaine, PCP, LSD. Okay, don't ask me what is that. I have it written. I do not, I don't memorize it. I cannot memorize it. It's very hard for me to memorize it. So PSP and LSD have signs of hallucinations. And you've got methamphetamines, so methamphetamines, and then you've got ADHD drugs like Ritalin. All right, so these are uppers, and if patients overtake Ritalin, they will have symptoms of substance use. And downers, everything else like heroin, alcohol, everything else is a downer. And what do we mean by upper? Like upper, it gets you excited, you're hyper, you're active. But downers, like alcohol, they bring you down. Okay, you feel that you're confused, you feel that you're lethargic, you're weak, and same with heroin. People who take a shot of heroin immediately go to an extreme high and then they sleep. Okay, so LSD is lysergic acid diethylamide. Okay, now you know why I do not memorize that. So it's one of the most important or most potent mood changing chemicals. It work very, very, very fast. Okay, and PCP is phencyclidine. Okay, all right. So the second slide are signs and symptoms. All right, yes, we're gonna talk about uppers, downers, excitatory, and inhibitory, but just be thoughtful about choosing your answers on NCLEX questions. So uppers, everything excitatory like euphoria, tachycardia, tachypnea, restlessness, irritability, diarrhea. Oh, there you go, diarrhea. Borborygmi. Does anyone remember what borborygmi is? Let me know in the comments. What is borborygmi? What is borborygmi? And then you've got seizures, and then you've got reflexes at +3, +4. They are usually uppers, excitatory. Does anyone know what borborygmi is? Oh my God. I told you guys, this is a very important word. It comes a lot on NCLEX questions. Actually, it doesn't come a lot, but NCLEX instructors say that it comes a lot. I've never seen it once, but I keep it in my slides just to make sure that you guys know it. If you see it, then you know that what borborygmi is. But yes, it is increased bowel sounds. Some of you like said different answers, which are wrong, but it is hyperactive bowel sounds. That's the definition. Hyperactive bowel sounds is borborygmi. Just Keep it in mind, guys. Downers. So everything inhibitory, everything down. So if you drink alcohol, you're lethargic, you're weak. The most important thing that you need to worry about is respiratory arrest. So patients who, addictive people to heroin, they know that they can they can choke and they can go into respiratory arrest. So do you know what they do? What heroin users do? They lie down in bed in a side lying position. Listen, listen. Heroin addicts, before they take their heroin shot, they lie down in bed on their side, lateral position on their side. They support their back with pillows, okay, just to stay on their side. And they apply the tourniquet. They take the shot in that, lovely vein, and then they remove the tourniquet immediately, and they will go into that high. They make sure that they stay on their side because one of the major side effects with heroin use, patients vomit, and that's why they stay on their side, because they don't want to choke on their vomit and aspirate and die. So you need to be aware of respiratory arrest, because down substances, or downers they call them, will cause the patient um, respiratory arrest. All right. So what equipment do you need to prepare if you have patients admitted with, you know, substance abuse that are uppers or downers? What are the equipment you need to prepare? For uppers, actually, you don't need to prepare anything. You just give antidote if there's an antidote, or if there's not, you just wait for it to wear off. But for downers, the two risk factors, or the two things that you need to worry about, are respiratory arrest and seizures. So just be sure, just make sure that you have seizure precautions in place, and you've got, your laryngoscope, your crash cart, your, your oxygen, your, whatever that has to do with that can treat a respiratory arrest or a, complication, respiratory complication. Alrighty, moving to the next question. Let me see. Let me see your math skills, guys. I want to see your calculation skills. A patient with congestive heart failure is prescribed to infuse 500 mLs of NSS from 6 a.m. till 1 p.m. or 1300. So sometimes on the NCLEX questions, you might have military times. So make sure you're familiar with them. The tubing on the unit have a drop factor of 20 Goots per ml. Which rate per minute will the nurse calibrate the infusion to deliver to the patient? Right, I know hospitals all over the United States do not have like regulator tubings. Everything goes through a pump, but NCLEX still asks those type of questions. So can someone calculate the rate for me? How many Good per minute? And let me know what is your answer. I'm gonna give you a little bit of time, because on your NCLEX, just take your time with those questions. Do the calculations once and twice before you pick up your answer. So it's 500 mLs over 7 hours. And then your drop factor is 20. Do I have answers? Hey, don't give me the formula, just give me the answer. Oh, you're giving me both, that's fine. Yeah, if you're giving me both, that's fine. That's even better, actually. Because now I know that it's not a fluke. You know what you're doing. Alrighty. Do I have answers? Give me some answers. I know some of you are saying, come on, shut up. Let me think. I know. Been there. Alrighty. I want at least 2 more of you guys to give me answers before I reveal the correct answer. Alrighty. I am You're happy with your answers. I just want to see one wrong answer before going forward. Does everyone, has everyone answered? I think I only see like 10 or 11 of you who answered already. Can I see more? No? You guys are not generous. Already. So moving on. So every single one of you who answered had the right answer, which is number 2. So you've got to give the 500 mLs over 7 hours. Okay, and then you've got the drop factor of 20. So this is the formula. This is how you go about it. And good job. So usually on your NCLEX, like 8 out of 10 or 9 out of 10 from nurses who sat for the NCLEX, they say that the first question is a calculation question. So it could be like dose calculation or rate calculation or something like that. All right, moving on. A 64-year-old patient with diabetes type 1. Okay, is diabetes type 1 insulin dependent? Just tell me yes or no. Is type 1 insulin dependent? Okay, awesome. I don't want anyone to do that mistake, all right? Awesome. Oops. Okay, so yes, type 1 is admitted to a new nursing home, but forgets to bring his prescribed medication with him. The patient states that he takes clear insulin and a white pill with a heart shape on it. What is the next action by the nurse that is most appropriate? So he takes clear insulin, so it's clear, you can see through, and then he takes a white pill with a heart shape. So what does the nurse do? I will call your primary care doctor to get your medication list. Number 2, do you know what are you taking the white pill for? So there's more assessment. Number 3, does the medication you take has any side effects? So she's trying to guess what's the medication from the side effects. And number 4, how long have you been on the white pill? What do you think, guys? Let me see. Cocktail of answers. Or someone is actually answering multiple answers. Always go with your first hunch, unless you misread something in the subject of the question. Otherwise, just go with your first hunch. If you're not sure, of course. Alrighty, so we've got a mix between number 1 and number 2. And usually it's 1, guys. Do not guess. Like, your license is on the line. Okay? Never guess. So clear insulin. So it could be it could be 100% you're talking about Act Rapid or Insulin R, but never take the risk. Why? Okay, you just call his provider, his doctor's office, ask what medication is he on, and then they will let you know. Do not guess. Okay, always, when you do medication reconciliation, always go by a list. Either the patient has the list, or he has his actual medication, or you call his doctor's office. All right. A 33-year-old patient newly diagnosed with brain tumor. Patient is 12 hours post infratentorium craniotomy to remove his brain tumor. So the patient is 12 hours post infratentorium craniotomy to remove his brain tumor. What positions are safe for the patient to place in? What positions are safe for the patient to be placed in? Select all that apply. Can someone give me the keyword? What's the keyword? I'm interested. What's the keyword in this question? Before you answer, just give me the keywords. Position, craniotomy, brain tumor. Okay. So actually, the keyword is craniotomy. Okay. So it's not brain tumor. It's like, what did you do with the brain tumor? All right, go on and give me what is, or select all that apply, right? So what are the positions that are safe for the patient to be placed in? Semifowler position, right lateral position, neutral midline head alignment, supine position with a soft pillow under the neck, slight hip flexion. So what are your answers? And there are tricks in this in the options, in the answers. There are some tricks, but trust me when I tell you that these are not my wording. So if you see right lateral position, so I picked that wording from a textbook. If you see slightly hip flexion, that is from a textbook. So I didn't make that wording for the position up. It's from a textbook. All right, so most of you answered. None of you got the right answer. Some of you got partially correct answer, but that's why we're here, to learn more. So the correct answer is actually 1, 3, and 5. So 1, basically, any patient with craniotomy or head trauma, or any patient who is at risk for high intracranial pressure, you put them in a semifowler position. Okay, you elevate the head of the bed a little bit. Number 2, right lateral position. I mean, whenever you see right, it is craniotomy, right? So you're talking about craniotomy. So why right? Why not left? Okay, so that's a little indication that this is not the correct answer. So if it was like only lateral position, then I might have considered it. But if it's right lateral position, then I would cancel it right away. Even though lateral position, like if a patient is having craniotomy, there's no reason for me to put him in a lateral position. Okay, if he's seizing, then after seizure, I put him in lateral position, or during seizure, or during seizure, you just let the patient seize. But after seizure, I put him in a lateral position just to make sure if he vomits, to drain whatever is in his oral cavity. Number 3, a neutral midline head alignment. Yes, that's correct. I want the patient to be in a neutral midline head alignment. I don't want him right or left, or twisted or whatever. So I would like the patient to be positioned in a midline head alignment to avoid extreme neck flexion or twisting. So I would like him to be in a midline head alignment. Number 4, supine position with a soft pillow under the neck. You never use pillow under the neck with craniotomy patients. Pillow out of the equation. All right, because you don't want to bend the neck. You don't want to flex the neck. You want to maintain proper airway, proper alignment of the neck, proper alignment of the head. Slightly hip flexion. So if you want to imagine hip flexion, it's semifowler position. So hip flexion, when you're flexing the hip, you're putting the patient in semifowler position. That's how you flex the hip. Okay? Flex the hip, extend the hip, then supine position. Flex the hip, then you flexing the hip. You're putting the patient at an angle. Do you get it? Yeah? Okay, awesome. Then there's one word in this question, infratentorium. So I wanted you guys to know what infratentorium is. It is that part right there. It is the separation between the brain, so the cerebrum and cerebellum, the brain and the cerebellum. That's called supra, that's the tentorium. Supra is above the tentorium. Okay, awesome. A 47-year-old, oh, you know what? Let's go take a quick break and we'll come back. Let's see. Let's come back at 10:33. Okay, let's take a 3-minute break. Come back at 10:33. All right, move around, do some stretching, and let's come back. Go grab your snacks as well. Alrighty, we are back. Do we have, okay, so we have 56% who already voted. Does anyone want to vote? Okay, I'm gonna close the poll. So I'm gonna share the results with you. 56% of you guys voted. 60% said that yes, they are on top of their daily notes, and 40% said 50-50. So the next question is why? Okay, why? Whatever excuses you're gonna give me, kids, family, university, life, business, 4th of July, whatever excuse you're gonna give me, it's not enough. As I said, the notes are complementary to the webinar. So if you get a question about SIADH in the webinar, I'm going through highlights, but honestly, if you do not know the definition of SIADH, then you need to read the notes to read the definition. Same thing for Parkinson's, same thing for Alzheimer, same thing for diabetes insipidus. I do not say the definition every single time. So if you do not know the definition, if you do not know basic stuff about congestive heart failure, hypertension, stuff like that, you need to read your notes. And sometimes in the notes, don't feel discouraged. Sometimes I'm repeating stuff. So if during this webinar we mentioned again SIADH, then I'm gonna mention again definition of SIADH. So getting through the notes will be easier. It's 30 to 45 minutes a day. Some of you are printing them out, highlighting stuff which I value. So please make sure that you are on top of your studies. Hey, listen, by the end of the day, you are the one who's sitting for the NCLEX, and I'm providing you with the resources to be able to pass. And as I said, 50% of the equation is knowing the right way to study and having the proper material. Okay, some agencies, especially for immigrants, like O'Grady or whatever, they give you subscriptions for UWorld or Kaplan and tell you, okay, go solve questions. So we're not doing this on this webinar. We're giving you slides that you're gonna see on your NCLEX. We're giving you resources that gonna help you, not just general resources that are dealing with everything. So make sure that you are doing your part and we are doing our part, and let's have a full equation with all the factors. All right, I'm gonna close the poll and I'm gonna share my keynote. All right, so moving on to the next question. So whoever is typing in the notes for everyone, and no one can see the notes. I believe no one can see the chat. So I can see the chat and I can reply back, but I'm not sure if everyone can see the chat. I don't think that everyone can see the chat. Alrighty. So a 47-year-old female patient is getting ready to being discharged after being treated for nephrotic syndrome. Which instruction is most important for the nurse to include in the discharge teaching? So we have a patient with nephrotic syndrome. What are the discharge teaching most important to include in discharge teaching? Monitor your blood pressure twice a week, switch to a low-fat diet, signs and symptoms of thromboembolism, implement a low sodium in your diet. What do you think? Give me your options. Give me your answers. All ready? Okay. All right. So I know this is a tricky question. Everyone was strict. All right. So basically one of you guys got the right answer, which is fine. All your answers are correct. Okay? I just want to make that clear. All your answers are correct. But you guys based your answer according to acute renal failure or acute renal insufficiency or chronic renal failure or chronic renal insufficiency. So you didn't pay attention to nephrotic syndrome. So nephrotic syndrome is different from acute renal failure or acute renal insufficiency or chronic. Okay, if and you have a definition about nephrotic syndrome in your notes, but basically the number one uh, the number one sign and symptom you need to monitor is number 3, thromboembolism. You need to monitor for clots because patients with nephrotic syndrome will have problems with their they will have peripheral vascular disease and they will form clots, and that's your first thing that you need to educate patients about clots. So if they have shortness of breath, chest pain, leg pain, uh, confusion, basically the patient will not know that he's confused. But if you're educating the family as well, so any of those signs is an indication of a thrombus. It could be in the brain, in the heart, in the lungs, or a deep vein thrombosis. So it is number 3. Number 4 is correct. Like, you tell patients to stay away from sodium, but the question is about the most important. So when you see nephrotic syndrome, you think about clots. That's it. Alrighty. The nurse instructs a client receiving. Oh, I like this question. So the nurse instructs a client receiving olanzapine. Olanzapine. Which statement by the client? Which statement made by the client to the nurse requires further teaching? So we're excuse me. Read the question again. The nurse instructs a client receiving olanzapine. Which statement made by the client to the nurse requires further teaching? Number 1, this medication will help my thoughts and behavior. Number 2, I must report restlessness to the healthcare provider. Number 3, I will tell the healthcare provider if I am planning to get pregnant. Number 4, stiffness and tremors are expected for the first 2 weeks. So basically, if we read the question again, which statement made by the client to the nurse requires further teaching? Alrighty. What are your answers? Okay, let's see. So some got the correct answer, but basically the correct answer is number. Can someone tell me what is olanzapine down in the comments? And don't Google it. Just tell me what is olanzapine. Awesome. Someone is on top of his studies. Awesome. You know, I love you guys. You're my A students. Or not A students, but you're my A buddies. Because you're really listening and you are on top of, your studies. All right, so moving on. So actually the correct answer is number 4. Stiffness and tremors are expected for the first 2 weeks. So they are a side effect, but they are not expected. If you see them, then you need to report them. Stiffness and tremors or extrapyramidal symptoms are a side effect of antipsychotic drugs. And now we're gonna go over all the antipsychotic medication slides. So we have around 14 to 15 slides. We're gonna go over all of them. We discussed those on day 2, but if some of you guys forgot about them, actually this is olanzapine. We said if you see the ZAP, then you know that this is antipsychotic. I think this is major tranquilizer. But if you see the ZAP, and we highlighted this in red in the slides, so make sure that you know this is antipsychotic, and the signs and symptoms go from A to G, A, B, C, D, E, F, G. E is extrapyramidal symptoms. So stiffness, tremors are expected. So they are known signs and symptoms, but you need to report them. Okay, you need to report them to the physician. So if you see expected, that means that this is expected. This is not important. You do not need to report it, but you do. Alrighty. So let's go over. So the rationale is stiffness and tremors are extrapyramidal symptoms and are reported immediately. This statement indicates a need for further teaching, of course. Okay. All right. So we're gonna go. So see the ZAP. You have to remember the ZAP. So it's a major tranquilizer. ZAP. So olanzapine is Zyprexa. That's um, a very common drug that's given as antipsychotic. And actually, this is another drug. So we said the olanzapine, and you might also see clozapine, which is a very known used drug in as antipsychotic. So these are actually the side effects with major tranquilizers. It's A, or just cancel the A. There's no A. So there's E and there's G. So there's E and there's G. The extrapyramidal symptoms, and then you've got granulocytopenia, which is low granulocytes, which means low immunity. Okay, so these type of patients will get infected very easily. So second generation atypical major tranquilizers treat severe schizophrenia, meant to replace zines and haldols. That's why you see they do not have a lot of side effects. For some reason, when they discovered this drug, they thought that it will replace the zines and the haldol, which is the what's the name of the haldol? The other name, decanoate or something like that. So, but the extrapyramidal symptoms, and most importantly, it has a severe granulocytopenia side effect. So so for a certain period of time, it was the drug of choice as antipsychotic for schizophrenia, but because of the high percentage of infection, the high statistics, then they started refraining from using this drug. Already? So we're gonna have a review. We have 14 slides to go through, so you guys gonna hear me talking. If you have questions, put them down in the comments, but let's review our slides. So psychotic drugs. All psychotic drugs cause hypotension and weight gain. That's a fact. All of them cause hypotension and weight gain, except for Prozac, weight loss. That's an NCLEX question. Prozac causes weight loss. That is an NCLEX question. Just keep it in mind. Zines, as in phenothiazines, these are first generation typical antipsychotics. They also call them major tranquilizers. Okay, you've got second generation, like the medication that we just talked about, the olanzapine. These are second generation major tranquilizers. The zines are first generation typical antipsychotics, which are major tranquilizers. So they are not a cure. Antipsychotics are not a cure. They are to control symptoms. So any patients that you have that has any mental disorder, they will not be cured. Okay, you hear about rare cases here and there, like patients with bipolar, they took medication for like 3 or 4 years and then they got off medication, they're doing very well. Okay, you will hear rare cases here and there, but the general rule is there's no cure, but you can control symptoms and make those patients functional in life so that they can work, they can drive, they can, function in life, socialize, get married, have kids, stuff like that. So large doses are used to control psychotic symptoms, but low doses, so psychotic symptoms like delirium, hallucinations, illusions, flat affect, and we discussed those on day 4. So if you think that you cannot remember the definition of delirium, okay, what is a what is that? Psychotic delirium or um, delirium dementia, or no, like psychotic delirium, or so there are types of delirium, and there are types of dementia, and then you've got psychotic psychosis and hallucinations. What are the types of hallucinations? Auditory, visual. Are they reality based? They are not reality based. Like you need to understand psychology so that when a question pops up, so you understand what are the psychotic symptoms and how to differentiate between them. Because a patient with delirium, you would treat him differently from a patient who's having hallucination. And a patient who has a reality-based depression, you will treat him differently from a patient who has a non-reality-based depression. So make sure you review day 2, I believe, or day 4, actually, day 4, slides of day 4. They are very, very, very important. So small doses, they are given as antiemetics like Phenergan or uh, compazine. They also have the zine. So Phenergan is chlormethazine or chlorpromethazine. They have a zine at the end. So that's why they call them the zines. All right. And then deconate, which is the Haldol, for those non-compliant patients. If they are not compliant, they're not taking their medication, you bring them into the clinic, you give them an IM shot of decanoate, and then they are good for 1 month. Okay, you bring them every month for the shot. So psychotic drugs, major tranquilizers, we're going to talk about side effects. Okay, and side effects between all anti or psychotic drugs medication are similar. There's minor differences, so you can memorize them very easily. So side effects for major tranquilizers, we're going to go with alphabetically: A, B, C, D, E, and F, G. A is anticholinergic effect, mainly dry mouth. Anytime we talk about A, just remember dry mouth. Okay, anticholinergic side effect. B, blurred vision. C, constipation. D, drowsiness. E, extrapyramidal symptoms. In some families, the E is different. Here it's extrapyramidal symptoms. And then you've got F, just remember photosensitivity or photophobia. But you have to tell the difference between photosensitivity and photophobia, as we discussed in an earlier webinar. Photosensitivity is when your skin is sensitive to light. So you wear long sleeves, you wear a hat, you wear sunscreen just to protect your skin. But photophobia, it hurts your eyes. You're afraid from the light. Your eyes are afraid from the light, so you wear sunglasses. G, granulocytopenia, which is low immunity. Always, 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 these patients, if they tell you what is the most important nursing diagnosis that you need to work on, it's always has to do with safety. Okay, safety is the most important nursing diagnosis. So it could be risk for fall or risk for injury. So any of those. Benzodiazepines, which are minor tranquilizers, they are fast acting. They call them the zip zap. Zip from the family name, and the zap, you will see it in the drug. That's why they call them zip zap. Zip is the family, benzodiazepines. Zip with the E, it's in the drug, like diazepam, lorazepam. These, they work very quickly, 3 to 5 minutes. They will take their effect, their indication is alcohol withdrawal. Most patients who have alcohol withdrawal, they are irritable, they are all over the place. So you give them Valium or Ativan. And then you got before surgery, patients who have anxiety before surgery, you give them lorazepam. It's a muscle relaxant. And for patients who have seizure, you give them IV midazolam or Valium, just to relax their epilepsy. Treat it very quickly because they work very fast, 3 to 5 minutes. So status epilepticus. Status epilepticus. This is a definition, but basically it's a dangerous condition in which an epileptic seizures follow one another. What does that mean? There is something called recovery phase. It is the medical terminology for it is lucidity. Okay, what does that mean? So when a patient has a seizure, before he is fully awake and conscious, like what do I mean by conscious? Like when a patient gets into a seizure and then he is reactive. So you talk to him, you say, "Hey, sir, do you know what's your name?" And he says, "Paul Smith." Then this patient is conscious, okay? Because they are reactive, they can answer, their brain is functioning well. So you ask them a question, they responded. But if a patient had a seizure and then they wake up after a seizure, but they are not conscious, they cannot reply to a verbal command. Like if you tell raise your hand, and they do not raise your hand, they look right and left without talking because they don't understand what's going on, and then they go into another seizure. So before they get into full recovery, they go into another seizure, and then another seizure. So 2 or more seizures back to back without recovery is very dangerous to the brain and to the nerves and to everything, and it is called status epilepticus. All right. Okay, so benzodiazepines, minor tranquilizers, side effects, as we said, alphabetically. A, anticholinergics, dry mouth. B, blurred vision. C, constipation. D, drowsiness. It's gonna always be the same, so just memorize it. So with major, you go from A to G. With minor, it's small. You go from A to D. You have to keep in mind that benzodiazepines actually work from 1 to 3 minutes. They start working. I said 3 to 5, but it's 1 to 3. Do not take more than 4 to 6 weeks. And then, so if a patient is taking lorazepam for more than 4 weeks, for more than 4 to 6 weeks, then you need to switch them to major tranquilizers. Okay, you cannot keep them on lorazepam for a long period of time. If they are taking it as needed or PRN, then that's fine. But if they are taking it as treatment, then after 4 to 6 weeks, you need to switch them to major tranquilizers. And again, most important nursing diagnosis is, yes, it's risk for injury or risk for fall. It has to do with safety. All right. Tricyclic antidepressants. There are 4 drugs I want you guys to memorize. And as we said, Eventyl, Deseril, Elavil, Tofranil. Just memorize them. When I did my NCLEX, I just memorized them. Because if you get a psychotic drug that is in a tricyclic antidepressant, you're gonna get one of those. So make sure you familiarize yourself with them. I do not. I mean, if you can predict a way to memorize them, let me know. But just figure out a way and memorize them. So usually these drugs and most of the psychotic drugs, they take 4 to 6 weeks to start working. So if a patient came to you and they said, "Oh, I've been taking the drug for 3 weeks, but it's not working. I'm not feeling any better." So you tell them that it takes 4 to 6 weeks to start working. Can be given for a lifetime. Side effects, as we said, always starts with A, anticholinergics, which is dry mouth. B, blurred vision. C, constipation. D, drowsiness. E, no, it's not extrapyramidal effect. Tricyclic antidepressants have E as euphoria. They get happy. How would you guess? Okay, so it's antidepressant. Those patients are depressed. We want to make them happy. That's why E, euphoria. All right. Moving on. The same thing. Nursing diagnosis. It's safety. Risk for injury, risk for fall. Monoamine oxidase inhibitors. They call them MOIs. You might see MOI, the abbreviation in the NCLEX question, or you might see the whole thing. Monoamine oxidase inhibitors. It is an antidepressant. When you think about MOIs, I want you to think about 4 drugs: Parnate, Nardil, Marpan. Parnate, Nardil, Marpan. So a way to memorize them, as I think, what's her name? Remar, or maybe Mark Klimek. One of them came up with this: Par Nar Mar. Okay, Par Nar Mar. Just try to recognize them. So if you don't want to memorize them, try to recognize them if they come into the NCLEX question. So if you see Parnate, then you say, oh, yeah, that's the par, and this is MOI. Then you start thinking about MOIs in terms of diet or side effects or tyramine or whatever MOIs have to do with the drug. But if you do not know that this drug is MOI, then you will not be able to answer the question. Alrighty, so call them the Parnar Mar, call them the Marnar Par. I mean, whatever you want, whatever works for you. So side effects, as I said: A, anticholinergic; dry mouth; B, blurred vision; C, constipation; D, drowsiness. That's it. That's it. Only 4. Just like what do you call them? What do you call them? The minor tranquilizers. Okay, because they're minor, they only have 4. MOIs only have 4 side effects from A to D. Again, the nursing diagnosis is safety. So monoamine oxidase anti-inhibitors, they are antidepressants, and patient education that you need to give is very important, because those patient population might have hypertension that is lethal. So to prevent hypertensive crisis, you need to give tyramine, tyramine, tyramine education. Tyramine could be found in several food, so we're gonna talk about them. So avoid all tyramine containing food. Fruits, veggies, and grains do not contain tyramine. So you tell them fruit, veggies, and grains, you can eat them, no questions asked. But there are some food that have minor tyramine in them, and they can have them. Okay, so mild or minor tyramine, they can have them, but just be careful, monitor your blood pressure. Avocado, banana, canned food, or dried fruit. Okay, so those, they can have them, but just be careful, monitor your blood pressure. The things that they cannot have. So if a question asks so like a food menu selection, if you have mild tyramine food, then it's fine, just disregard it. Look for food that have a lot of tyramine in them. We're going to talk about them. The patients have, they cannot come close to these food selection. So we are talking about organ meat like liver, lung, kidney, intestine, any organ they cannot eat. If you see the word cured, smoked, or dried meat, or fish, sausages, salami, I think it's like pepperoni, they cannot eat them. They have a lot of tyramine. And then anything that has to do with dairy, aged cheese, yogurt, do not come close to them. Chocolate, caffeine beverages, stay away from them. Over-the-counter drugs that has the word elixir on them, do not come close, because they are very high in tyramine. So whenever you see the word elixir right there, and let me see, elixir right there. So these food, you stay away from them. These over-the-counter medication, you stay away from them. Lithium is a family, a lot of bipolar drugs. So bipolar disorder drugs are lithium-based therapy. So what do? Are they given to all bipolar disorders? No, they are given to the mania. So with bipolar, it's bi because it has two phases. It has the depression phase and the mania phase, where the patients are hyper, happy, jumping all over the place. So lithium, they decrease the mania phase, not the depression. They decrease the mania phase. So this is the only drug that does not mess up with neurotransmitters, which means that there is no ABCDs. What side effects do I have with bipolars? Okay, I have triple Ps. Can someone remember what are the triple Ps? If not, that's fine. I'm gonna slap you on your face and now memorize them. They are triple Ps: paresthesia, peeing, and pooing. Paresthesia, peeing, and pooing. Paresthesia is numbness and tingling of extremities. Paresthesia is numbness and tingling of extremities. Okay, with lithium, we said that the normal is 0.6 to 1.2. 1.3 is fine, it's slightly off, but anything above 2 is toxic effect. So, what are the toxic effects, right? They are seizures, metallic taste, severe diarrhea, heightened reflexes. Why did I put heightened reflexes? Okay, I'm giving you a new medical terminology. Sometimes you see heightened reflexes in the NCLEX questions. Usually it means hyperreflexia. So +3 reflexes, +4 reflexes are hyperreflexes. Usually +2 is the normal. Anything lower than the 2, which is +1 or 0, means the patient is hypo. It has hyporeflexes. All right. So what is the normal level? I know every one of you guys know 0.6 to 1.2, similar to creatinine. Serum levels of therium above 2 are lethal. Okay. We need to memorize those, guys. Prozac is very important medication that you see on your NCLEX. SSRIs, classic antidepressant. Okay. And now when we talk about side effects, they're gonna be A, B, C, D, and E, and the E is not gonna be extrapyramidal side effect. Why? Because this is antidepressant. I want to make the patient happy. All right. So similar to the tricyclic antidepressants, the Eventyl, Desoril, Elavil, Tofranil. So similar to the Elavil, they need 4 to 6 weeks to start working. They can be given long-term treatment. Side effects, as we said, A, dry mouth, B, blurred vision, C, constipation, D, drowsiness, E, yes, euphoria. All right. So patients who are on Prozac have another symptoms that is unique to Prozac, which is insomnia. I do not give Prozac afternoon time. So after 12 noon, I do not give Prozac because it causes insomnia. So I give it in the morning. Okay. And there is a how do you say it? Like an objection to the rule with another drug that causes insomnia, but you give it at night, which is the Zoloft. We're gonna see it. So Zoloft has insomnia side effects, but you give it at night. And you're gonna ask why? I don't know. No one knows. So just memorize it as it is. All right. So these patients population, I mean, a Prozac, certain patient population who take Prozac are at risk for suicide. Who are they? Risk for suicide, especially at dose change in young adults. Okay, when you if the medication is not working and you change and you increase the dose, just pay attention that young adults might be at risk for suicide. Haldol, it's the only safe drug for pregnant women. It's a major tranquilizer, and it's like the Zines. It is first generation typical antipsychotic. Side effects, you know by now, right? A, dry mouth. B, blurred vision. C, constipation. D, drowsiness. E, is there antidepressant there? No, so it's extrapyramidal symptoms. F, photosensitivity. We already talked about the difference between photosensitivity and photophobia. G, granulocytopenia. Nursing diagnosis, safety, Haldol in pregnant women. If they are not compliant, then I'm telling you, pregnant women with, you know, with their hormones, sometimes they are not compliant. What do? You bring them to the clinic, you give them that IM shot of deconate, which is the Haldol, all right? A side effect for deconate is neuroleptic malignant syndrome. Actually, it's not a side effect, it's a overdose, a Haldol overdose. So if you overdose the patient or the patient overdose themselves, then they will have a neuroleptic malignant syndrome. What is the importance of the notes that I sent you after the webinar? They have definitions. So if you do not know the definition of neuroleptic malignant syndrome, hey, you're gonna find it in the notes, right? Always refer to the notes, guys, all right? So it's Haldol overdose. It is a toxic, life-threatening effect, popular among young white men and elderly. Why? I don't know, just the statistics. So neuroleptic malignant syndrome has a fatal, they call it, pyrexia is 40 degrees, which is hyperthermia, high temperature. Pyrexia, when you say pyrexia, you think about 40 degrees. These patients are always unstable. In the priority slides that we have, these patients are always unstable. But with neuroleptic malignant syndrome, you've got hyperpyrexia, which means more than 40 degrees. Usually it is between 104 and 108. So 40 degrees is 104. So it is higher than 40 degrees Celsius or 104 Fahrenheit. Um, do not mix between patients who have neuroleptic malignant syndrome and patients who have the what do you call it? The extrapyramidal effect or extrapyramidal symptom. They are different. So patients with hyperreflexia could have chills, could be shaking, but it's due to fever. It's not due to anxiety and tremors, right? So always check for fever if your patient is receiving Haldol. All right. So this slide, we saw it at the beginning. It's the second generation atypical major tranquilizer, clozapine. They are, this is the drug that they discovered, and it didn't have any side effect. They thought it's gonna do wonders. They started using it, but then they stopped using it because there is a very high risk for infection because it causes granulocytopenia. So it has two side effects. They are extrapyramidal side effects and granulocytopenia. So Zoloft, I told you guys, a very unique thing about Zoloft is that it causes insomnia, but I give it at night. So the Zoloft are similar to tricyclic antidepressants, the Aventil, Desaril, Elavil, Tofranil. So similar to the Elavil, they work after 4 to 6 weeks after giving the medication, can be given as a long-time treatment. And you say, hey Mo, like we understood, like why are you repeating it? Hey, listen, if you don't repeat it over and over again, then if it comes in an NCLEX question, you cannot recall it. But if you are able to recognize this, like when you see 4 to 6 weeks to start working, we already repeated that over and over again, then you would recognize it when it comes in an NCLEX question. You would recognize that antipsychotic drugs take 4 to 6 weeks until they start working, except for benzodiazepines, the zip zap, they are fast acting. All right, so it's always like repeating stuff, relating stuff to each other, comparing slides, comparing drugs. That's the way how you memorize things. That's why I like recalling slides and recalling images. All right. So side effects, as we said, so these are antidepressants. They have A, B, C, D. The E is not extrapyramidal side effect. Just because they are antidepressant, we want to make them happy. It's euphoria. So, and they have insomnia, as I said. And even though Zoloft have insomnia, you still give it at 9 p.m. before bedtime. Already? So, um, Zoloft, insomnia, but you give it at bedtime. You should give it at bedtime, actually. So it has interaction. It has certain interactions. So we're gonna go through them. So if a patient had interaction on Zoloft, you lower the doses, or usually it interacts with other drugs. It lower the doses of other drugs. It mess up metabolism, especially with warfarin. So if you are taking 20 milligrams of warfarin and you take Zoloft, then you are at risk for forming clots. So that's why you need to monitor the PTT. Nah, with warfarin, you monitor INR or PT. So you monitor your PT. If it starts dropping, then you need to increase the dose of Coumadin. So just keep that in mind whenever you're taking Zoloft and your patient is on Coumadin. That's how the NCLEX question comes. When you see Zoloft, a very common question is that they're going to ask you about Coumadin, or they're going to ask you about St. John's wort. So this is a flower, this is a plant, herbal. It is, you can see it a lot in products that has to do with depression or weight loss. Okay, so St. John's wort and Zoloft will cause you something called serotonin syndrome. So what are the symptoms of serotonin syndrome? 3Ds and NH. What are the 3Ds? Diaphoresis, dizziness, down effect, and the H is the headache. Is the headache like a regular headache? No, it is a severe headache, just like the ones you see in the hypertensive crisis with MOAs. And the serotonin syndrome, the H is headache due to a hypertensive crisis. Okay, and when I talk about hypertensive crisis, I'm talking about a systolic blood pressure of 220 and above. I'm talking about a diastolic blood pressure of 160 and above. So just keep those in mind. In real life, you really have to pay attention in hospitals when you have patients who are on psychotic drugs. You really need to know your medication and the symptoms, because if you encounter those, you need to act fast. Okay, this is life-threatening situation. Those are our slides. I hope you guys go over them. I think we will go over them one more time before the end of the webinar, just because of the importance of these slides. I cannot stress this enough. So moving on to the next question. A pediatric nurse is taking care of 6-month-old baby who is 6 hours post cleft palate repair. Which intervention by the nurse takes priority? Bear in mind, guys, so a cleft palate or any congenital lip disorder or deformity, when they come on the NCLEX question, they always relate them to feeding. That's a very common question. So make sure that you guys know. Number one, assessing and managing the patient's airway. Number two, addressing the patient's pain. Three, change of saturated dressing. Number four, feeding the patient. So which intervention by the nurse takes priority? Which takes priority? What are your answers? So someone is saying, can you repeat what you said, please? Well, I've been talking for the last 2 hours. Specify. All right, so what is your correct answer? Yeah, I was trying to trick you when I talked about feeding. You need to use your ABCs, right? So yes, you need to pay attention for feeding, but the patient just had a cleft palate repair. Okay, so the keywords in the question, they are not talking about feeding. They're talking about cleft palate, but you've got the 6 hours after OR. So what are the risks? What are the complications just less than 12 hours after surgery? There are two major complications that you really need to pay attention for. They are airway and bleeding or hemorrhage, because it's internal bleeding. So it's airway and bleeding. So it's number one, follow your ABCs, pay attention to the question. Don't just jump into, so I want you to know the information, right? Whenever you see cleft palate, yes, think about feeding, but don't be tricked or trapped. So they are testing your critical thinking and your knowledge. But when they say 6 hours post OR, there are two major complications that you need to pay attention for: airway and bleeding or hemorrhage. So just keep that in mind. But yes, feeding is very important because patients usually get blue and suffocate if they have a cleft palate. And if they did the surgery, then they solved that problem. They do not have a feeding problem anymore. But when they feed and they repair that cleft palate, what you need to pay attention is for the surgery site. Sometimes it tears and sometimes it get infected because of the proximity to the food. So the milk will go inside the wound and it will get infected. So just try to analyze and pay attention to those. All right, let's see another select all or apply question. A 29-year-old patient presented to the ED with dry cough, hyperthermia, chest crackles, severe headache, muscle weakness. Which nursing diagnoses are the most appropriate for the nurse to include in a plan of care? Select all that apply. Discomfort, risk for respiration, ineffective gas exchange, ineffective breathing pattern, risk for infection. Give me your options. So when you see questions like that, select all apply. What I do is I read discomfort, then I look at my signs and symptoms again. Is discomfort one of the one of the signs? Can it help one of the signs? Should I put that as a nursing diagnosis and start working on it to relieve the sign and symptom? So always brainstorm. All right, give me your options whenever you guys are ready. And with the real NCLEX test, so basically here in the webinar, I'm not giving you the time you need to answer questions. But tomorrow with your exam, just pay huge attention, take your time. I don't want anyone to finish the 75 questions in under 2 hours. And I want you to send me, when did you start and when did you finish? When did you take a break? Okay, I always encourage your breaks. Like when you are 2 hours in, go take a break, take a 15-minute break, stretch, eat a snack, and then come back and finish the rest. Okay, don't keep solving questions without taking a break. Just I want you to live the NCLEX test setting. Okay, most of you guys have done the NCLEX before. Just imagine yourself sitting at a desk, sit on a comfortable chair, and try to solve your questions. By 2 hours, the computer is going to ask you to take your break. Then go take 15-minute break. Okay, we're going to go over the test day. What are the rituals that you need to do a day before the test and on your test day, by the end of the webinar, because these are very important. They are of huge importance. So give me your options. No, I'm not gonna give you questions on this weekend that are really gonna test your level. So not like the first week. The first week, I wanted to make sure that you guys are reading your notes and following along with the webinar, understanding stuff. And you guys surprised me. Everyone was on point. Okay, everyone got above 70%. Okay, the desirable was for the first week was 80% and higher, or 85% and higher, but 70% is amazing. But I want to see 70% on the second webinar. Yes. So the correct answer actually is, and maybe one of you guys got the correct answer, is 1, 3, and 4. What happened? Okay, it's 1, 3, and 4. So 1, discomfort. That's an appropriate nursing diagnosis, especially with patients who have inflammation in the lungs or muscle pain. So patients with crackles, dry cough, muscle weakness, they are at discomfort. So number 1 is like when I'm doing nursing documentation, in the hospital where I work at, and I'm typing very fast because I have a lot of patients, and I have a lot of phone calls. So you need to put a nursing diagnosis there. I always put impaired comfort, because wherever you put it, wherever the situation, it is a right answer. It is a right nursing diagnosis. So if they are auditing, they will not say, oh, this is a wrong nursing diagnosis. Because if the patient has diarrhea, like, you can put diarrhea as a nursing diagnosis, but you can also put impaired comfort. So always choose impaired comfort. Okay. Let me see. Risk for aspiration is not. So I would not put risk for aspiration. The only time I would put risk for aspiration if I have a patient with CVA, or a patient is vomiting, or a patient like a pediatric patient. I would go ahead and put risk for aspiration. But like in this case, I don't see why you would choose risk for aspiration. Okay. So ineffective gas exchange, that's obvious because of the chest crackles. So if a patient has fluid on his lungs or pulmonary edema, then they will definitely have ineffective gas exchange. Number four, ineffective breathing pattern. That's also obvious because of if the patient has fever, they might have ineffective breathing pattern. The chest crackles, the dry mouth, dry cough. I mean, all that will go into this nursing diagnosis. So number five, risk for infection. Um, so that is incorrect. Just for the fact. So I'm reading back the. So I see hyperthermia. Hyperthermia is that. I guess that's tricky. I would choose risk for infection as well, because it's a risk. If it was infection, then I would not choose it. But if hyperthermia and I link it to risk of infection, yes, I would choose it. So 1, 3, 4, and 5 are correct answers. Okay, let me see who answered 1, 3, 4, and 5. Okay. Yay. Oh my God, you guys are blasting in the comment section. Everyone is talking about 5. Yes, so I was going through the rationale just like you guys. I put this question a long time ago. So I missed 5. Yes, so 1, 3, 4, and 5, whoever answered those, or whoever included 5, yeah, you're right. It makes sense because of the hyperthermia. This is a risk for infection. All right, moving on. I like the way you guys rationale. That's how you should rationale in SATA questions. A new mother tells the nurse that she wants to exclusively breastfeed. And you guys have seen a lot of breastfeed questions because they are very common. Labor and delivery, breastfeeding, they are very common on the NCLEX. The nurse reviews a newborn nutrition with the mother. Which statement by the mother indicates successful teaching? So basically, which is true statement? So four are gonna be wrong and one's gonna be true. A 4 month At 4 months of age, I will start mixing baby cereal in the milk bottle to give to my baby. So basically, she's gonna mix the cereal in the bottle and give the bottle to the baby. I will throw away any breast milk in my freezer that is more than 4 months old. I will introduce baby cereal at 3 months of age to help with the growth. My baby girl has enough iron stores from my breast milk that will last her 4 months. Fun fact, with English language, when there's months, like 6 months, so you pronounce it as S instead of TH, but when you pronounce month, like 1 month, you pronounce it as TH, month. And I didn't know that. Actually, my wife corrected me. So if you see all my YouTube videos in the early, ages, like first year or so I always say 6 months. All right, give me your best answers, guys. What is your pick? Try to rationale. Okay, try to analyze those answers before picking them up. Already. So you guys still thinking? All right, awesome. Okay, so actually, the correct answer is number 4. I know I see a lot of ones, but we're gonna explain like, so what basically number 1 is saying that you put the cereal in the milk and inside the bottle and you shake it and give it to your baby. So you do not do that. You do not mix the cereal in, because first off, it will block the nipple of the bottle. They will not go through. And second thing, your baby might aspirate on them, because a 4-month old baby or infant, they are used to drinking milk. If you start introducing particles, because basically when you put the cereal in the milk and you shake it, they will form particles. So the baby will aspirate on those. And usually you do not start, so you start like solid food by the age of 4 to 6 months, but not in that form. So this is a wrong way to start cereal. Okay, just for the fact that it is a bottle. So you mix it with a breast milk or a milk formula, but you do not put it in a bottle. Number 2, I will throw away any breast milk in my freezer that is more than 4 months old. That's incorrect. It is 6 months old. So the breast milk can stay in the freezer for 6 months. That's the expiry date. Number 3, I will introduce baby cereal at 3 months old. So that's wrong. Usually you introduce as by the textbooks at the age of 6 months. Okay, but I mean, as you guys know, everyone starts feeding by the age of 4 to 6. But usually, as per the textbooks, it is 6 months. And then number 4, which is the correct answer, the mother gives iron to the baby that is sufficient for the first 4 months of life. After 4 months, then the child should take iron formula. Okay, already. Let me see your comments first. Yes, yes. Yeah, I mean, always with those type of questions. That's why I say, I swear to God, I swear to God, it's very important to read the subject of the questions 3 times and choose keywords. And when you move to the answer, try to use cancellation strategy and try to analyze. When you cancel, try to analyze why you're canceling. Do not cancel if you're not confident that this is wrong. If you're not confident, just keep it. Okay, you're not confident, just keep it. Cancel whatever you're confident. You should at least cancel one, and then use NCLEX strategies to pick up the correct answer. But I don't want you to get a wrong answer. So getting a wrong answer because you do not know the information, that's fine. Okay, most probably that's a high intensity question, high difficulty question. But to get a wrong answer because you misread the information, first off, this is unfair to yourself. Okay, you have put a lot on the line, and then you get a wrong answer because you misread, like you rushed it. Take your time, guys. Time is not your enemy, only wrong answers. All right, so moving on to the next question. A senior nurse on the med-surg unit was promoted to a charge nurse 2 months ago. The staff are unhappy with the decision. Which action by the charge nurse is best during staff meeting? Try to help the staff. Try to help the staff every now and again. So the charge nurse will try to help the staff every now and again. As I said, you might not be familiar with the charge nurse role in the United States, but charge nurse role does not take patient assignment. The charge nurse is responsible for all the patients on the unit, but they are not responsible for, if this medication is receiving blood or he's having signs and symptoms. That's the RN job. Okay, the charge nurse makes sure that the work is flowing, the rounds are happening, like the multidisciplinary rounds, if a physician wants to put orders or wants to start a procedure, or there's an emergent situation that needs the charge nurse attention, the charge nurse will take care of it. If there are transfers or discharges, for nursing homes or stuff like that, the charge nurse will coordinate those, work on the charts, on the discharge process, on all those kind of stuff. But they do not attend patients. So if we say try to help the staff every now and again, that's not the charge nurse's job. Okay. Sometimes on nursing units, there's a nurse called a resource nurse. Resource nurse is someone who would help with busy shifts. Like if an RN has 3 patients and one of them was like high acuity, and she is late on her like afternoon medication administration, then she can ask the help of the resource nurse to help her with whatever. Or if she has a procedure, she can assign that procedure, delegate it to the resource nurse, so the resource nurse will stay with the physician and help with the procedure whatsoever. All right. So number 2, give the staff some more time to adjust to the change. Number 3, return to the staff nurse position. Number 4, explain the promotional opportunity and the added value that the charge nurse have brought to the position. So, I mean, most of you got the right answer. Always try to analyze and, try to cancel. So number 1 and 3, obviously they are not correct. Okay. So definitely she's not going to return to the staff nurse position, and definitely she will not help every now and then. Number 4, so she does not have to explain herself why she took the promotion. Okay. So she does not have to explain herself. Just give time for the nurses to heal. Already. What is that? Oh, okay, so change. Okay, so give them time. An alcoholic patient is discharged with liver cirrhosis. Which intervention is most helpful to the patient's situation? Okay, a patient with liver cirrhosis, which intervention is most helpful to the patient's situation? Low sodium IV albumin. So I'm gonna give him low sodium IV albumin. It will help his liver cirrhosis. Kegsalate enemas, placement of Blakemore tube, low protein, high carbohydrate diet. Try to analyze before you pick up your answer. After this question, we're going to take a quick break, 2-minute break, and then we'll get back at it. Alrighty. So a patient with liver cirrhosis. Try not to overthink, the questions and go a lot into pathophysiology. Just keep it simple. Alrighty, most of you actually got the right answer, or let me say like 70% got the right answer. Which, if you didn't get the right answer, that's fine. We are explaining the rationale just to learn from it. So patients with liver cirrhosis, they have problem with metabolizing fat and protein. All right, fat and protein. So I do not give a patient albumin. So I do not give them albumin because they cannot metabolize it, right? So I do not give albumin. There's one case I give albumin to a liver cirrhosis patient, and we're gonna discuss this later. But here, that's not the case. So I do not give albumin, IV albumin for liver cirrhosis patient. Kegsalate, there's no indication. Usually patients with kidney failure have high potassium. Then I give Kegsalate to lower it. But in this case, hey, listen, be patient. I'm gonna tell you what's the case. Not now, at a later stage, today, but at a later stage. So Kegsalate, I only give it for patients who have high potassium, and usually those patients are acute or chronic renal failures. Number 3, placement of Blakemore tube. I'm not sure if you know what's Blackmore cube. We discussed this in a different terminology in a previous webinar, but I put it there to discuss it again with this terminology so that you guys would know both terminologies and why do we use a Blackmore cube. So, so basically we use a Blackmore cube for patients who have gastric or esophageal bleeding. Yes, liver cirrhosis patient might bleed, but this is not the case right here. So if they didn't say that this patient is bleeding, why do I need to think? So liver cirrhosis are 4 stages: stage 1 to 4. Only end stage, which is stage 4, liver cirrhosis patient might have gastric or esophageal bleeding. Then I might need to place a Blakemore tube. But this is not the case. Okay, so do not overanalyze stuff. Only what's in the subject of the question. So basically, that leaves us with number 4. Patients with liver cirrhosis, I give them a low protein diet, low fat diet, and I give them a high carbohydrate diet just to preserve their energy. Alrighty. Um, so real quick, I'm gonna give you treatment for potassium imbalances. What are the treatments? We talked about those before, but I just want to touch a little bit about um, some of the things that you might encounter. So we talked about hypokalemia, hyperkalemia, but there are so you're gonna see in the questions hyper and hypo, but the the NCLEX question come in a different way and ask you something different, just like that cleft palate. You know, they mentioned cleft palate, you've got feeding in the options, but they are asking about something else. So this next slide is about that treatment for potassium imbalances. So basically, if you have patients with hypokalemia, you're gonna give potassium, right? But if the question says potassium IV push, then no, you do not push potassium because that will cause a cardiac arrest or at least a ventricular arrhythmia, which is very, very dangerous. Which bring us, are you guys on top of your EKG arrhythmias? I hope you are. Very simple, 6 or 7. If you if, just like the Mona Lisa, if you see a Mona Lisa, you will recognize that, right? I want you to consider those as piece of art. So if you see a ventricular fibrillation, you would know it. Ventricular tachycardia, you would know it. Torsade de pointe, you would know it. Bradycardia, tachycardia, supraventricular tachycardia. You can tell the difference between supraventricular tachycardia and irregular tachycardia. Supraventricular tachycardia usually have a heart rate of more than 150, and they do not have a P wave. Just basic stuff, art. Consider them as art. So please, please stay on top of your studies. All right, so never give IV potassium as IV push, okay? And so if you have any question that the provider is ordering more than 40 mEq per liter, you question that order. So do not give more than 40 mEq per liter of potassium. I know, I mean, before you write in the comments, I know some of you might say, we still have like 30 minutes on the webinar for today. It's a longer webinar, but we were finishing early, so we still have 30 minutes. Let's see. So NCLEX setting, they would like you to stay safe. So safe is 40 mEq per liter. Like if you are on the unit and you see 60 mEq, yes, you question the order, but then the physician is gonna tell you, shut up, just follow the order. You questioning the order is legit during the NCLEX setting. During like real life setting, if you see 60 mEq per liter, you just talk to your charge nurse. Your charge nurse will say that's fine, and then you go on with your life, okay? But with the NCLEX, just make sure if you see 60 and they are asking which order do you question, then you question this order. Hyperkalemia, we talked about D5 water, we talked about insulin. What is the insulin, the top choice of insulin, or the only choice of insulin when you are talking about IV insulin. It is Actrapid or insulin R. So insulin, as I said, it's like a key. It opens the door for potassium to go inside the cell. The normal place for the potassium to be present is intracellular. Okay, so it is intracellular. Intracellular. So cakes lowers potassium, but it takes time. It takes 2 to 3 hours to lower the potassium. It can be given through an NG tube, and we discussed those cases. Like if you have a patient who's psychotic and he removed his peripheral IV, but he has low blood sugar. Oh, that's a low blood sugar. So he has a low blood sugar, and you only have an NG tube and a D10 or D50. Then you give that D50 in the NG tube and rescue the patient. So same with Cakesalate, you can give it NG tube, oral, or enema. It is a slow form of treatment. It takes 2 to 4 hours. Okay. And just pro tips about electrolyte imbalances. I put them there. When you have paracentesis or paresis in the options, and they're asking you select all that apply, always select those. So it doesn't matter if it is hypokalemia, hyperkalemia, if it is hypocalcemia, hypercalcemia, if it is hypomagnesemia, hypermagnesemia, if it is hyponatremia. Okay, I know. I've seen someone say shut up in the comments. So any electrolyte imbalance, and you see select all that apply, and you see those symptoms or those signs in the options, you choose them just blindly. Paracentesis, paresis, which is muscle weakness, and numbness and tingling in the extremities, just choose them. Always select paracentesis and paresis and select all that apply questions, okay? This is a quick tip. All right, so Blackmore tube is actually this tube. Have you seen it before? Of course you've seen it. We talked about it. How did we talk about it? We talked about the esophagogastric tube. So it's the same thing. You inflate it, especially when you have a patient who has gastric bleeding or esophageal bleeding. This is a life rescue situation. So sometimes you have patients who are bleeding, they are vomiting blood, and you do not have an OR ready, or the patient is in the ER, and you do not have time to send them to the OR. You do not wait on them. You do not, like let them bleed. You insert a Blakemore or esophagogastric tube, and you inflate it to prevent the bleeding. Ready? All right, moving on. During a wellness child visit of an 8-month-old baby, the nurse is to perform a physical assessment on the infant. What is a good technique for the nurse to use? We're going to take a break after this one. What is a good technique for the nurse to use to physically assess the child? Do not wake the infant to auscultate the heart sounds. Fully undress the infant to do a physical assessment. 3, ask the mother to hold the infant during a physical assessment or physical exam. Number 4, start the physical with assessing the nose and throat. What do you guys think? So someone is saying that we use the Blakemore in diverticulitis. Please review the slides from yesterday, or just Google diverticulitis. Diverticulitis is in the colon. It's pouches in the colon, pouches like in the colon. The food or the stool will stay in those pouches, and then they will cause cancer over a long period of time if they stay there. But diverticulitis are in the colon. So most of you got the right answer. It is ask the mother to hold the infant during a physical exam. Number 1 is wrong, because you need to wake up the patient when you auscultate the heart and lungs. Because you cannot. So if you want to auscultate the heart, you have to listen to the heart in different positions, and you cannot listen to them with the patient sleeping. So you wake him up. Okay, and usually, so yeah, that's the case. So number three, you always, I mean, as a pediatric nurse, we always ask the parents or the mother or the father to hold the infant, and then you do the physical examination. You do not fully undress the patient. You keep the patient in his diaper. Okay, the genital area you assess last. So you always keep the patient in their diaper um, before, before what is that? If when you physically assess them, just keep them in diaper, assess them, and last thing you assess the genital area. And number four, start the physical assessment with assessing nose and throat. No, no, no. That's a no, 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 no. In pediatric population, maybe in adults you can do that, but the invasive and the traumatic assessments you keep them to last. Okay, so you assess the level of consciousness, the eye, lymph nodes, you palpate, you auscultate. But if you want to look in the nose or the throat, use a tongue depressor, you keep them to the end of the physical exam, because then they'll start crying and they will be fussy and all this kind of stuff. The nurse calls the mother of a patient diagnosed with let's take a break. All right, let's go ahead and take a 3-minute break. Whoever is sleepy, wash your face and come back. Whoever has a backache, go stretch a little bit, do some pelvic exercises. I'm just kidding. But yes, let's take a 3-minute break. Let's be back at 11:51. Alrighty, we are back. I hope everyone is back. Let's answer this question. So a nurse calls the mother of a patient diagnosed with antisocial personality disorder to follow up the patient's progress with therapy. The mother states that the child looks way better and is accepting great responsibilities. Which response by the nurse is best? That is awesome. I'm happy to hear that. Or statistics shows that children with antisocial disorders do not drastically change. Number three, continue this medication and therapy even if you see improvement. Number four, walk me a little bit through the new responsibilities your child has been taking. What do you guys think? Alrighty, awesome. All right, so whoever answered got the right answer. So actually that is number four. And I would like you to really pay attention when you have like a psychiatric disorder and they are talking about communication. So with communication strategies with patients, how to deal with them, what's the right thing to say, stuff like that, always pay attention to yes or no and open-ended questions. Okay? Pay attention to recognize feelings. Do not be sarcastic. Okay? Pay attention to state the reality. Don't go with the delusion. Like if a patient is talking about mafia and they are going to kill us, don't run away with the patient and say, yeah, let's hide. They're gonna kill us. They're gonna kill us. You know. So pay attention to those stuff like open-ended question. Do not ask yes or no questions. Address feelings before starting your assessment or addressing other stuff. Address feelings, then state reality. So pay attention to those. If you need more examples, you need to go and review day 4 because we explained everything. So basically, number one, that is awesome. I'm happy for you. That this is not right because you are not giving the mother a chance to give you more information. You're not assessing more. You're just stopping there. You're ending the conversation. Number two, it is stating fact, but before stating facts, you need to gather more information. Number three, continuous medication again so these are true. 2 and 3 are true, but before stating fact, there's a better response. Number 4, you need to know. So you're assessing what are the responsibilities, tell me more. You're asking an open-ended question. Okay, just a brief definition or brief, shedding some light on antisocial personality disorders. People with antisocial personality disorders tend to antagonize. manipulate or treat others harshly or with callous indifference. Okay, I tried to look this up. It looks like this word, like I tried to translate it to Arabic just to try to understand it. It's a definition. I didn't get it, but you know, if I mean, if you want to pay attention to it, that's great. If you don't, just understand that people with or patients with antisocial personality disorders usually manipulate others and treat them aggressively, violently, all these kind of stuff. This shows or they show no guilt or remorse for their behavior. Individuals with antisocial disorders, especially kids, often violate the law and become criminals in the future. So a kid with antisocial disorder is a future criminal. Fun fact. All right. So a patient diagnosed with a liver cirrhosis, and whoever asked me who was not patient, when we talked about liver cirrhosis just a while ago, this is your question. This is the other case. A patient diagnosed with liver cirrhosis is admitted to the med-surg unit with ascites. Which treatment will the nurse expect the doctor to order? Albumin, aldactone, what's that? Nabumetone, fresh frozen plasma. Which is the correct answer? Which is the correct answer? Let me see. I do not have answers yet. Or I do. All right, what do you think, guys? Do I have answers? All right, so this is a tricky question, and it is here to educate you about liver cirrhosis. So this is the thing. We said with liver cirrhosis in the previous question, with the liver cirrhosis, if you have a patient with liver cirrhosis, alcoholism, whatever the case is, it's affecting the liver. What you need to focus on is low protein, low fat, because the patient cannot metabolize those properly, right? And any medication that is excreted through the liver, you need to pay more attention to it because it will stay in the liver for a longer period of time. So the half-life will be more. So one of the medication that is metabolized by the liver, and it's very popular, is Coumadin. Coumadin, which is warfarin, metabolized by the liver, and it takes time. So if you have a patient with liver cirrhosis, then it's going to take them time to excrete the warfarin from the blood. So if they take Coumadin at 9 a.m. and then after 24 hours, not the full dose of Coumadin was excreted, and then you give another dose. So after a few days, you will have accumulated dose and you'll put the patient at risk for bleeding. So, but in this case, pay attention. So liver cirrhosis is admitted to the med-surg unit with ascites. Ascites or ascites, however you want to pronounce it, it is fluid in the peritoneal space. So that's a peritoneal fluid. They call it ascites, and you'll have abdominal distension. The patient will start having shortness of breath. It depends on the degree of the ascites. So patients with liver cirrhosis at an advanced stage 3 or 4, will start having liver cirrhosis. So treatment for ascites will start having ascites. Treatment for ascites is either peritoneal tab, where they will put a cannula in the peritoneal wall, in the abdominal wall, and they will drain the fluid. But when they do that, they are putting the patient at that oncotic hydrostatic pressure difference, and they will put the patient at risk for fluid imbalance. So what they do is that they drain the ascites, and for every liter drained, they will give 50 milligram or I think 1 vial, which is 25 milligram of albumin. But if they do not want to drain, they do not want to perform a peritoneal tab or abdominal tab, or they call it peritoneocentesis. If they do not want to perform this procedure, they will give albumin to the patient. So when you've got extra albumin in the blood, the extra albumin in the blood will affect the oncotic hydrostatic pressure, and then it will pull all the interstitial. So any fluid in the third spaces, the albumin will pull it into the blood, and then it will get excreted. The fluid will get excreted by the kidney. Okay, is that clear? So patients with ascites, you give them albumin, though they have liver cirrhosis. All right. But if the subject of the question is saying just liver cirrhosis, they're not talking about anything else, and they're giving you options. What is the best option? I mean, yes, you stay away from albumin and protein. Already. So albumin is a hyperosmotic protein solution. It pulls fluid back into the bloodstream. All right. So albumin is albumin. Aldactone is a potassium-sparing diuretic. The nabumetone, this is actually like an NSAID that has a side effect as peptic ulcer or gastric ulcer, and patients with liver cirrhosis are already at risk for bleeding, so this is an added risk for bleeding. That's why this is incorrect. And fresh frozen plasma, I mean, if you give fresh frozen plasma to patients who are bleeding, so there's no signs of bleeding. Already, a 66-year-old patient, a 66-year-old patient has been diagnosed with diabetes mellitus type 1, which is the insulin dependent, for 10 years now. Patient is at risk for left big toe amputation. What is the best goal the nurse would set for the patient's plan of care? So we are setting a goal. Normalize cholesterol level, take safety measures while riding his motorcycle, maintain good glycemic control, take oral antidiabetic medication as prescribed. And if you know diabetes, you would immediately answer. And if you know diabetes, you can do cancellation strategy. If you know diabetes, you can immediately get the correct answer. But let's go. What do you think? Come on, engagement. Whoever's sleepy, wake up. We're almost over. We have like less than 10 minutes to go. We're ready. Do I have answers? All right, awesome. So everyone who answered actually got the right answer. So just, excuse me, just to highlight just one information. Diabetes mellitus type 1, it's insulin dependent. The most important thing with insulin dependent is medication. So it's insulin. Okay, medication, then exercise, then the last would be diet. So medication is very important. And how do you give the insulin to the patient? Is it standard, like you give 10 units in the morning or before every meal? Or is it according to the AccuCheck? Yes, it is according to AccuCheck. So let us say, this is an NCLEX question. Let us say a patient is sick and he's not eating. So the wife is saying, oh, I don't want to give him his insulin. He did not eat today. What do you say? Shut up, lady. Take his AccuCheck and give insulin according to the sliding scale. So you always give insulin according to the sliding scale, according to the AccuCheck. If it is high, you give insulin, even though he's not eating. It doesn't matter. Stress increase the a glycemic effect in the blood. So the number one you need to put as a goal is maintain good glycemic control. Alrighty? Awesome. So the quick definition, low production of, I mean, you already know by now, which leads to abnormal metabolism of carbohydrate and elevate levels of glucose in blood and urine. So diabetes mellitus could be type 1, which is insulin dependent, type 2, oral medication. All right. So a 54-year-old patient with a long history of cigarette smoking was diagnosed with laryngeal cancer and had a laryngectomy done. The home care nurse instructs the patient's daughter on how to suction the patient's laryngectomy tube, which observation indicates effective teaching. So basically the keyword is suction. Okay, the nurse is teaching the daughter to suction. And obviously he had a laryngectomy tube, so, or laryngectomy. So it's not like an endotracheal tube or, you know, like that. So number one, the daughter asks her mother to take several deep breaths before starting the suctioning process. Number two, the daughter uses a yanker to suction the patient's laryngectomy tube. Number three, the daughter applies suction while both introducing the catheter into the tube and out of the tube. So she's applying oxygen on the way in and the way out. The daughter suctions the corner of the mouth from saliva and then the laryngectomy tube. So what do you think is the correct answer? What is the correct answer? All right. So I have right answers and I have wrong answers. And this is put, I mean, this question is put for a reason to teach you guys about different techniques. All right. So, all right. So I would say 70% got the right answer, which is number one. The daughter asked the mother to take several breaths before starting the suctioning process. If you have a patient on a mechanical ventilation and he has a tracheostomy or an ET tube, then you are going to hyperventilate the patient with 100% oxygen for 2 minutes before performing suctioning. Okay, that's a fun fact. If you work in critical care, you would know that. If you don't, know it. So so that's a fun fact, number one, that it's true. Number two, the daughter uses a yanker to suction the patient's laryngectomy tube. You do not use a yanker for a laryngectomy tube. You use the yanker only for saliva in the mouth or vomitus. So if a patient had a seizure and he's vomiting and you want to suction his mouth, you do not use a suction tube. You use a yanker, okay? And I understand hospitals overseas do not use yanker, but that's very common in the United States. Three, the daughter applies suction while both introducing the catheter into the tube and out of the tube. That's wrong. You only suction when you are going out of the tube. Or the daughter suction the corner of the mouth from saliva and then the laryngectomy tube. You do not do that. You do not go from a dirty place to a clean place. So the mouth is dirty and the larynx is clean or cleaner. So you do not go from the mouth that might have food and saliva and a lot of microorganisms and then put it in the laryngectomy tube. Okay, so this is a picture of a laryngectomy. So this is the stoma. You might have a tube here like a tracheostomy. So same thing for tracheostomy. So if a patient has a tracheostomy or a laryngectomy, they will have the same stoma, and you will go through it to suction, and you use the same technique. Already? And the yanker, this is the yanker. This is the part from here till here. It's a hard plastic part. that this yanker, you do not use it to suction the trach. Okay, the yanker, you only use it to suction the mouth. And this is like suctioning tubing or whatever. All right. Okay, moving on. I think this is the second to last question, or the last question. A patient is admitted from the emergency department complaining of headache. Blood pressure is 188/102. The patient is known to have a history of hypertension. The nurse should assess the patient's medication adherence. Which statement made by the patient indicates proper medication adherence? 1. If my blood pressure is high in the morning, I do take another dose before bedtime. Number 2. I usually take my blood pressure medication just after breakfast at the same time every morning, never missed a dose. Number 3. I monitor my blood pressure every morning. If my blood pressure is normal, I skip the dose. Number 4, on the weekends, I hike. I take my medication after the hike on the weekends. What do you think is the correct answer? Let me see. So I've got right and wrong answers, but that is fine. Even though we discussed blood pressure medication, on the first day, on day 1. So you need to review that webinar or, the slides or the notes. So basically it's number 2. This is how you take the blood pressure medication. You take them every day at the same time after breakfast. After breakfast, because if you take them before breakfast, they might give you stomach problems or stomach discomfort or epigastric pain. So usually you take blood pressure medication just after breakfast every time at the same time in the morning. Okay. So number 1, if my blood pressure is high in the morning, so like the patient cannot manipulate his dose of blood pressure medication. So this is not insulin. You do not have a sliding scale. Okay. So if your blood pressure is high, you need to consult with your physician, and then they might switch medication or change the dose. Number 3, basically it's the same thing. You cannot skip doses. And number 4, you cannot fluctuate the timing. It should be at the same time every day. All right. So this is the last question. A patient is financially challenged. Financially challenged means that he's financially unstable. Patient calls the nurse to ask if he can substitute a prescribed pantoprazole with over-the-counter antacid, which is with a cheaper price. Which response by the nurse are appropriate? Select all of the apply. So number 1, let us try the antacid for a week and we'll give you a follow-up call then to see how you feel. 2, let me check with the pharmacy about the cost. 3, pantoprazole is a selective proton pump inhibitor, a medicine which reduces the amount of acid produced in your stomach. It is used for treating acid-related diseases of the stomach and intestine. Number 4, caffeinated beverages can also help in the ulcer healing process. Number 5, I will email educational videos about smoking cessation. Number 6, call the clinic if you experience black tarry stool. So what education do I give to the patient? Or what is the appropriate response by the nurse? What do you think? Awesome, I already have the correct answer. So there's a trick, there's a trick in this question. If you understand what the question is asking you or what the question wants from you, then you would easily pick up the right answers. But if you don't, then you will not. All right. Do I have, oh, everyone answered at the same time. All right. Basically, I only have one correct answer, and the rest are, you didn't pick up all the options. You missed one or two. All right. So the correct answers, let's go over them, analyze them, and then I'll give you the correct answers. So number one, let us try antacids for a week, and then we'll give you a call. Like, so what is the question asking you? So the question is saying that the physician prescribed pantoprazole, which is Protonix. If you're in the States, Protonix, that's the medication. So pantoprazole is a proton pump inhibitor. It's not antacid. There's a difference between PPIs and antacids. So you cannot replace those drugs. So basically, if the nurse is saying, okay, let's try antacid, then she's giving him another drug that does not, it has a different function. So number one is incorrect. Number two, let me check with the pharmacy about the cost. That's valid. If he's saying that it is expensive and he's looking for a cheaper price, maybe the physician ordered the generic form and they can have or they ordered the, so there's generic and there's, what's the other thing? Generic and, whatever, like generic and brand or whatever. So there are two types of, drugs, like generic and what's the other word? Oh my God. Anyways, so they can look for cheaper price. One is more expensive than the other. So they can look for cheaper prices. So let me call the pharmacy and ask if there are cheaper prices or promotions or deals, every two get one, or, pharmacies always have source like organizations or sources that help with certain drugs. Some drug companies have offers on drugs. So calling pharmacy to ask about the cost is a legit answer. So number three, basically she's explaining the difference between a proton pump inhibitor and antacid. So that's education. Yes, you include that. Number four, caffeinated beverages can also help with the ulcer. Of course not. They will make it worse. So number four is wrong. So for now, 1 and 4 are wrong. Number five, I will email educational videos about smoking cessation. That's correct. Here in the United States, we do email patients videos, like you order the patient a video. So you order, like if you're ordering blood level, like if you're ordering a CBC, you can also order like a Lovinox teach video. So you order the video and the video will go to the patient's email, and then the patient can watch the video. And from your end, you can tell if the patient watched the whole video, skimmed through the video, or just watched like 2 minutes of the video. Okay. And so that's number five is a legit answer. And number six, call the clinic if you experience any tarry stools, because if the Protonix is not doing its job, it's not protecting the stomach, and you're having gastric ulcers, it will show as bleeding, and upper GI bleed will manifest in the stool as tarry black stool. It will not manifest as fresh blood. All right. So yeah. This question is not about. So who? So. Oh, wait a second. Yeah. So number five, yes. So smoking cessation videos, because they cause gastric ulcer. So smoking cause gastric ulcer. So I gave an example about Lovinox because I use it in my work. But so those type of patients, because they are at risk for gastric ulcer, and smoking causes gastric ulcer. So you send them educational videos about smoking cessation. All right. Okay. I hope I explained that. All right. So correct answers are 2, 3, 5, and 6. One of you got the right answer, and that moves us to our last slide, which is our quote for today. Today, our quote is by Winston Churchill. If you are going through hell, keep going. If you are going through hell, keep moving forward. We are at 2 weeks from the webinar. 2 weeks are in the history, are in the books. We still have 2 more weeks. If you are stressed, if you are overwhelmed with information, if you think that this is too much, I would encourage you to take a step back, reflect, and remember why you're doing this, and double, double down on the time you're investing in your NCLEX. Okay, you've came this far. You invested so much. You are going through hell. You've been going through hell for a long, long time. 2 more weeks. I cannot stress enough on the importance of investing every single minute towards reading NCLEX material. So if you are wasting time, TV, YouTube, spending time with your kids, saying, oh, I'm entitled to spend some time with my kids because I started hard today, or I started 6 hours today, let me go spend a couple of hours with my kids. No. Okay, no. Don't go out on weekends. You still have 3 more weekends. Do not go out on weekends. If you want to go to the gym, grocery, so these are the activities that you are allowed to do. Go to the gym and listen to the podcast. Grocery shopping and listen to the podcast. Walk your dog and listen to the podcast. Walk around the block and listen to the podcast. But do not go out with friends, family, or with your kids. Okay? Just leave that responsibility to your spouse and focus on your NCLEX. Invest every single minute with your NCLEX. I know how you feel. I've been there. A lot of people have been there. My wife has been there. You've been there multiple times. You know how it feels. But it's not worth that feeling when you are checking your results and you fail. It's not worth it. You would say, oh my God, I got those slides. I watched those webinars. I had those information. I didn't master them. I failed. So if you are going through hell, please keep pushing forward. Double down on the time that you are investing towards your NCLEX. Some of you are doing an amazing job. You're on top of everything. I can see that. We've been communicating privately. I love the fact how excited you are to sit for your NCLEX. So if you are not excited to sit for your NCLEX, that literally means that you're still not confident. So please review your slides and stay tuned for the exam tomorrow. Please, everyone, there's 19 of you. 18 actually are active, one is not active for some reason. 18, I want 18 results to be sent to me. You can send them via email, via WhatsApp, Facebook Messenger, or Instagram, whatever platform we communicate on. Please send them before Sunday, 6 p.m. Central Standard Time, just for the fact like it literally take me around 6 hours to finish 18 of you. So if I start at 6, I'll finish at midnight. If I start at 8, I finish at 2 a.m. I just want to be able to send you the analysis, and I know you are so excited to see your answers and how well you did and how's your performance, your graph, your performance graph. Because like trust me, this weekend the graph's gonna differ from week one, weekend number one. So love your faces. I hope everyone is energetic, excited for tomorrow. That's it for tonight. And thank you for giving me this opportunity to make a difference in your life. See you on Monday. And I'm also excited to get your answers and grade them and see you succeed. All right. Have a good night or have a good morning.